I really want to take this opportunity to thank you for joining us and to welcome you to this webinar. We have a whooping 885 registrations, so we know that there's a lot of colleagues that want to get these ethics points as we chase the 31st of March deadline for CPD submissions in the HPCSA. So colleagues, this is the program of the day. I'm going to start you off. I'm facilitating this session until about 17:30 or so, when I will hand over then to Dr. Sharon Nkeruka-Haba, who is our chairperson of the South African Registrars Association. We have an amazing program for you, and we hope that you can stay until the end. So without saying too much, I'm now going to ask our CEO, Dr. Mzulungile Nodigida, to welcome you to this webinar. Over to you, CEO.
Oh, thank you very much, Z, and good afternoon to colleagues from wherever you are in the country and wherever you are in the world. SAMA views itself as a leader in healthcare, and as we know that there are very rapid and almost ever-changing landscape within the health sector, one of which is the introduction of AI and its application in healthcare. All of these, in our view, we view them as frontier issues within healthcare, and therefore leadership and especially clinical and ethical leadership are very, very important. So sit back, relax, and enjoy as we deliver to you this webinar today. And we hope that you will learn quite a lot by the end of the webinar. And thank you very much for joining us this afternoon. Thank you very much, Z. Let me hand over back to you. Thank you.
Thank you very much, Dr. Nodigida. So colleagues, we will start off with our first presentation, which will be given to us by Dr. Chris Matthew. Dr. Matthew is currently the Health Informatics Officer for the South African Private Hospital Group, Netcare. In his role, he also serves as a clinical lead for Africa's largest EMR system, through which Netcare has established the first fully digitized hospital in South Africa. Prior to joining Netcare, Dr. Matthews trained as a medical doctor and then went on to complete his MBA, and he followed by a master's in international health and tropical medicine. So both of these he obtained from the University of Oxford. He is passionate about healthcare and technology and the ever-expanding intersection of the two, and the role that this will have in improving healthcare for all Africans. So please welcome Dr. Chris Matthew. Thank you.
Perfect. Thank you, Sianda. Let me share my presentation quickly. So I just want to make sure I'm sharing the right screen. 2 seconds. Just share again. Okay, Zianda, if you can just confirm that you can see my screen.
Yes, thank you so much. We can see it, Chris.
Perfect, thank you. Okay, good afternoon, everybody. Thank you all for joining me today, and thank you to Zianda and the team at SAMA for allowing me and inviting me to present today and to share some of my thoughts and my experiences. As Zianda mentioned, my name is Chris Matthew. I am the Health Informatics Officer for Netcare. And for the past few years, my role has been entirely focused on the implementation of our EMR system in our hospitals. I'm going to put my camera off just I find it's a bit distracting, but I'm sure you guys you've now seen me and you've seen the presentation, so I don't think you need to keep it on. But yeah, so as I mentioned, I've been responsible and entirely focused on the implementation of our EMR care on in our hospitals for the last few years. And as Yanda mentioned, we're very proud to be the first and at least for now the only fully digitized hospital group in South Africa with EMRs across all of our divisions, from our acute hospitals to Net 911, our emergency services, our KSO clinics, our mental health division, Medicross in our primary care space, national renal care, cancer care, as well as occupational health. And look, this journey has been challenging in many ways, but also equally rewarding, and in ways that we could have never anticipated. While many of us now embrace the benefits that we have of digitization, when we started this journey 7 years ago, pre-COVID, there was a very different perception of technology, and we were dealing with quite a vast spectrum of users, from nurses who had never touched an iPad or a smart device, doctors who were still using old Nokia flip phones and 3310s, if you can believe it, to doctors who had fully seamless digital workflows and fully digitized practices. So as we went on this journey and as we became paperless, we encountered various hurdles, obviously some that were expected, like infrastructure, training, change management, and the like. And while those were obviously challenging in their own way, they were manageable. The tougher challenges, though, were the ones that kept us on our toes, were the human factors. And how do we ensure that going digital doesn't compromise our clinical care or our values as healthcare professionals? How do we use these tools responsibly, or how do we maintain trust with our patients and with each other? And what you'll see as I go through some of my thoughts today is ultimately there's no perfect answer. It's a balancing act between the two ends of the spectrum, along with everything in between. So I'd like to share some of those lessons today, and share some of the lessons that we've gained from the digitization journey. And I'll explore this through 4 themes. The first being a comprehensive digital patient record. The second, digital tools and a new way of work. The third, transparency and accountability. And then lastly, the human factor. So let's start with the first one, which is really the foundation of a digitally enabled hospital, and that's a universal, comprehensive patient record. It is a completely new way of working. Imagine a patient that comes into your practice or comes into your hospital, and at the touch of a button, you can instantly see their entire medical journey. Every encounter they've had at any neck care facility, every lab result, every X-ray or MRI, every single dose of medication that was prescribed or administered, and even those that weren't administered. From the moment they walk in, through every admission and every follow-up, the data is there, what we call cradle to grave. This kind of universal patient record was a foreign concept for most of us before CareOn. And in the paper world, patient information, it's siloed, it's fragmented, it's episodic, it's spread across different files and different locations, often incomplete or inaccessible when you really actually need it. But now that we have this comprehensive record of each patient, the question then becomes is how do we take advantage of this both effectively and responsibly? So one of the first and most obvious benefits, which I'm sure most of you will easily appreciate, is that all the information is digitally recorded. And this quotation I have on the screen is one I like to reflect on and share. It's one of the physiotherapists when we first went live with CareOn at Mill Park Hospital back in 2019. And she said to me, Chris, for the first time, I can see and I can read the notes of doctors. And most cases we sort of laugh or smirk at this, but it was the reality is that many cases doctors wouldn't write notes in our files. And if they did write notes, they were very scanty or barely legible. So now for the first time, you actually have everything all in one place and very clearly and easily legible. If we then think about that from the risk or the the error perspective, this obviously means that there's a reduction in medication errors. We looked at various literature and various studies, and over 60% of medication errors in hospital are attributable to illegible handwriting. Another study also found that 52% of medication or adverse drug events could be avoided or addressed through an EMR, simply by catching issues like wrong doses or drug interactions. But the real strength of this is not just about the reduction of errors, it's actually the value add it provides in clinical care, creating a single record across the continuum of care. You have a single patient record wherever they were. A patient that was admitted in ICU last month and now comes back to ED, you can see exactly what happened, the antibiotics, the vitals, the discharge summary, and even the ventilator settings, without hunting down a physical file or trying to fumble through some sort of a history taken with the patient or their family. And all of the patient's history, their lab results, their radiology reports, it's all captured in one place, giving you a completely consolidated, comprehensive view of the patient's data and information. Helps us to avoid duplication, any delays. And obviously, having all of this data in one view immediately improves the quality and safety of care. However, as the cliche goes, with great power comes great responsibility. So we can't forget that this is still a record. It is a collection of sensitive personal information, and you have to still treat it with integrity, respecting patient privacy and confidentiality at every step of the way. And this is where the legislation then becomes extremely important. And here, there's various themes that we cover in the Acts. We talk about access and privacy, or sharing data and retention. So I'll go through each of these in relation to the Acts. I'm not going to give you a legal lesson, but just to highlight where the legislation guides us. Sorry, I clicked ahead there. But the first act and the most important act is the National Health Act, and specifically focusing on sections 13 to 17. So these sections cover the creation, the maintenance of the record, sharing of the record, as well as the consequences for any contravention of the act. And to summarize these sections, the records can only be shared with the consent of the patient, or if needed, between members of the patient's healthcare team, for whom the patient would have inevitably consented, because they would have consented to receiving treatment from these members of the team. If we then look to the Protection of Personal Information Act, what we all know as POPIA, Section 32 specifically prohibits the processing of patients' personal information. However, in this case, there's an exemption in the context of healthcare and in the treatment and care of the patient, which also aligns well to the National Health Act. Then the third act to consider, the Promotion of Access to Information Act, or PIA, as you may note, and specifically sections 30 and 61, where the Act then makes provision for access to a record to be denied if it's deemed to be potentially detrimental to the physical or mental well-being of the patient. And then lastly, if we look at the HPCSA booklets, looking at booklet 5 on confidentiality, this aligns directly and perfectly with the Act. And critically, while all of this legislation provides for access to healthcare professionals involved in the care of the patient or part of the healthcare team, we also have to be very careful of where we cross the line or where we draw the line. Perhaps you're a nurse who wants to check on a colleague or a friend who's been admitted, or you're a doctor who wants to check in on one of your family members, or maybe even your child that's been admitted to hospital. And you can easily justify or you can rationalize these scenarios, but ultimately keep in mind that neither of them are really appropriate, because you're not accessing the record in the context of providing care to the patient. And that's always important to keep in mind in terms of how you navigate this. And then lastly, in terms of retention of the record, as I mentioned earlier, a look into HPCSA Booklet 9 provides guidance on how long records should be stored for. Ultimately here, it provides a minimum guidance, but doesn't really talk to a maximum, although you could interpret some of that from POPIA. But here, the real core dilemma is establishing a balance between storing versus disposing of the records. And in most cases, this is actually dictated by the cost of the storage and retention, which is extremely high in a paper environment, but less so in terms of unit costs in a digital environment. And obviously, if you can then tackle those costs, it is more justifiable to store those records indefinitely. And that's exactly how we've approached it. We've committed to covering the cost for the lifetime of the patient to ensure that the full record is available as and when needed. and really sort of taking us and supporting us in the aim of a cradle to grave record of the patient. So really, what does this come down to? And it's the integrity that we need to maintain in using these comprehensive records. And we need to respect the boundaries that are established, the boundaries that legislation provides. There's obviously incredible value and benefit that these records have, but we still need to protect the information that's there, that's contained therein, from our own curiosities or potential misuse. And if we look at the guidelines in the Act, we need to ensure that the comprehensive record remains a tool for good. It's there to empower us to provide better care, but ultimately still to ensure we uphold patient rights. Now, with the foundation of the electronic record in place, let's move on to the next aspect, and that is digital tools and a new way of work. When we moved from paper to digital, it became very clear very early on that we can't just keep doing what we've always done. We have to adapt. We have to embrace a new way of work. If we simply wrote or printed all the forms and scanned them in, you would, in theory, have an EMR. You would digitize your processes, but you've not really gained any value out of the digitization. You need to look for ways to rather incorporate the tools directly into your workflow to make you more efficient and effective. And it brings me to, or reminds me of one of our greatest success stories. It's a busy physician. He works at one of the hospitals in Johannesburg, often managing 40 to 60 patients at a time, if not more. And he fully embraced the change. He reimagined his ward round routine. He starts his day usually between 3 to 4 a.m. And he starts with a virtual ward round where he reviews all of his patients. He reviews their vitals, their results, reports, medication, whatever's happened in the last 24 hours. And he prepares his notes and his management plan for each of these patients. And then by the time he actually arrives at the bedside, he's already up to speed on every patient, and he can focus specifically and directly on the patient in front of him, talking to them, examining them, and actually finalizing the plan in real time. If something needs more thought, he can finalize that after seeing the patient. But by mid-morning, his ward rounds are done and all his documentation is up to date. He essentially leverages the record to completely front load his cognitive work and allowing then for more of the quality face-to-face personal interaction with each of his patients when he gets to the bedside. But my favorite part of this isn't actually directly related to care, and it's the same doctor. He's taken it even further than that in the way he manages the communication with his patients. So when he goes back to his office, he then also sends a short voice note to a specific nominated individual from each family, but every single family will receive an update. Every single day, he does it diligently and without fail. It's a one-way communication, but he sends a concise update consistently. He manages the expectations and he addresses majority of their routine questions and ultimately alleviates their concerns. And just by acknowledging that they are patient, they are human beings, and having that empathy, but also making that effort to consistently manage that process, he then actually creates a better experience for his patients. Now, obviously, not all of us will start our ward rounds at 3 a.m., but the point here really is that if you find a way to adjust your way of work and make the technology work for you, you don't need to just replicate what you did on paper. You need to reimagine what you did on paper and adapt it to an electronic environment. At its core, an EMR and the various digital tools, they can't replace us as clinicians. They're just there to enhance and augment us. And something that's so critically important in our context and our environment where we are so short of resources. And that gives me a good segue into the next section, which is around clinical decision support, CDS, and how that augments your ability. So what do I mean by CDS? And in a nutshell, CDS refers to any digital tool or system feature that provides support in making a clinical decision, but does not actually make the decision for you. So it's just there to support you in that decision. It can provide advice, reminders, guidance, still all supporting your decision. And it can range from simple alerts like a pop-up telling you your patient is allergic to penicillin when you try to prescribe Augmentin, to more sophisticated guidance like providing drug dosages in relation to a patient's weight or their GFR, or suggesting medication in response to abnormal lab results. It's not there yet again to replace you. It's just there to support you, to still allow you to exercise your own clinical autonomy, but to nudge you in the right direction, give you pause and ask you to reconsider if maybe you might have perhaps made a mistake. You can use things like order sets or what we call profiles in Careon, which is just a collection of medications or clinical orders that are all bundled together and would typically encapsulate best practices. And this allows you to then submit those all in one tap or one click. Yet again, all of this is trying to do is help you make the best possible decision, augmenting your knowledge with the diligence and thoroughness of a machine or a system that can remember all the guidelines that you can't. But how does this now then relate into AI and AI's use in healthcare? So the HPCSA, as I'm sure a few of you are aware, they recently released booklet 20, which I think is still in draft form technically. And it's all about the use of AI in healthcare. At its core, as we would expect, it advocates for patients, prioritizing their best interest in their outcomes. Things like privacy, confidentiality, autonomy, dignity, everything we would expect from such a booklet and guideline. And what it says is AI should serve as a tool to support and enhance clinical decision-making rather than replace it, exactly like what I said earlier. Ultimately, AI should complement the expertise of health practitioners, ensure that human judgment remains central to patient care while leveraging technology to achieve greater efficiency and effectiveness in healthcare delivery. So while an AI tool can suggest a diagnosis or perhaps suggest or guide you to a treatment or according to a guideline, the decision-making must still always reside with you as the healthcare practitioner. This guideline, it also calls for transparency with the patient in front of you. If you are using AI while you're providing care, patients have a right to know, and in understandable terms, that AI is being used and how. There's a vast array of tools, and I'm sure many of you have engaged with a few of them already. There's plenty available out there for you to make use of, so I won't go through those in detail. There's some incredible stuff that's happening, and every week we see something new. But there are some comments I do want to make, or one specific comment rather, is the most valuable use cases that we're seeing and the opportunities for technology in healthcare actually don't really need AI. They just need the time and the effort put into creating structured logic and algorithms. We have all this hype around AI and what AI can do for us, but we're often missing the basics. We're missing the low-hanging fruit that can be solved through simple and basic logic and thought processes. So in summary, digital tools, CDS, they can all greatly enhance and support the clinical care when they're used well. But to really get the full advantage, we need to adapt and adjust our workflows. And no matter how smart the systems are, it always relies on us as the clinician to make the final decision. The technology is there to assist us, to inform us, to remind us, to prompt us, to nudge us, but that human element, that engagement and oversight remains key. So how do we embrace these tools? Or as we embrace these tools, we need to also question them, refine them, and keep ensuring that they serve the goal of better patient care. So now that we've covered the benefits of a comprehensive record of digital tools, let's also unpack how these changes affect our approach to record keeping. Just click through. So one obvious or seemingly obvious change is that a digital system gives you a completely deep, thorough transparency to your record keeping. In an EMR, there's a clear audit trail with nearly every action being date and time stamped. Every time you access a file, every result you review, every note you write or don't write, and every prescription or order you capture. Each step is date and time stamped. The system will automatically say who did what and when, which obviously this can sound intimidating or can sound punitive, but it's also beneficial. In most of the medical legal cases, and we look back at our case over the last 20 years, and over 90% of our cases were attributable to poor record keeping, or simply the complete absence of a record. We had no way of defending ourselves. And this is something that EMRs can solve instantly. In most cases, we're not being intentionally negligent or malicious. It's just that our record keeping really lets us down. From an ethical standpoint, obviously, this aligns with our professional responsibility. We need to keep good records, and we are often so poor at doing so. If a medication was due at 2 p.m. and it was only given at 4:30, the chart or the EMR will show why there's a delay, and it will force the nurse to include a reason. Or maybe it was given on time, but they just forgot to do the record keeping. It's just there as that extra check and balance to ensure that that record is managed responsibly, which is vital to the accuracy and the completeness of the patient's file. And in a well-designed EMR, what you also want to ensure is that altering the records is difficult and actually almost impossible without leaving a trace. It's a deterrent to people potentially falsifying records. It helps us to maintain the integrity. And this is also where HPCSA Booklet 9 comes in and provides guidance on how to alter or amend information, that no information should ever be removed. And really, you never want anything to be removed. Obviously, there might be clinical risks that you need to consider if you don't remove the information, but the way in which you amend the data or remove the data becomes important. Having an audit trail becomes important. Putting a line through it on paper, or in our case, we gray it out and we include a reason for why it was deleted. But that audit trail is always visible, so you know why that data was deleted. So if you ever go back to court in 20 years' time, you have the information there readily available. Importantly, though, this can obviously very easily slide into a punitive type of culture. If users or clinicians feel that the data or the record has been used to punish them, it motivates you to find gaps, to find ways to work around the limits of the system. You ultimately defeat it. So you need to accompany this with a culture of trust and learning and growth around the data, around the system, and how it benefits and supports you, and ultimately emphasizing the value it will offer. And this is obviously not from the perspective of the healthcare provider, but this is equally important from the perspective of a patient. The transparency we can provide for patients is that we now, as we digitize, we're moving towards patients actually having access to their own records. We talk about patient portals, where in our environment, we have a Netcare app where patients can access the information directly. And in many countries, in first world countries, it's the norm. Patients can read their clinical notes. They can read everything the doctor writes about them. And obviously, we're not quite there yet, but I don't think we're too far off. And we've taken the first step. All of our patients automatically get a copy of their discharge summary, what we call the summary of care. Soon we'll also give them access to their results and reports and other clinical information. But what then becomes important is actually how we engage with our patients. How do we educate them, empower them, and help them to take ownership of their care? This empowerment, this autonomy that we give them will allow them to then become what we refer to as active participants in their health and care, something that we strive for, this model of participatory healthcare. It's how we really can move towards better outcomes. And obviously, as we now provide more and more access to each of these people and each of these users, I'm sure all of you are thinking about what about the risks that come with this. And that's obviously where the concerns around cybersecurity and data protection may come in. And I can give a whole talk on this about how we've approached it and how we've tackled it. Suffice to say, it continues to be one of our biggest and highest concerns. And we need to continually reinforce our security protocols. And we had a major downtime issue last week. It's not about it not happening. It's about being prepared for when it does happen. And there's that preparedness is that what really ensures that continuity of care and minimizes any risk to the patients. Okay, I think I'm not doing well on time, so let me speed up a little bit. The last section I want to focus on and hone in on is, we can talk about data and tech and all the tools, but the most important part really of all of this is the human being. And the human factor in this is at the core of everything that we do. And whether for better or for worse, even the most advanced digital systems rely on human beings, on our nurses, our staff, our doctors to enter information, to interpret that information, and ultimately to act on it to deliver care for that patient. So how we cater for that human behavior in our design then has a fundamental impact on the success and the value of our EMR. And when we designed our system, we unintentionally, and to our detriment, we assumed perfect human beings that would follow every prompt, every protocol, read everything on the screen, do exactly as we expected them to do. And obviously, as you can expect, or as you can guess, we very quickly learned otherwise. If there was a way to find a workaround or to break something, the users would do it. And that's just it's the nature of human beings. It's how we interact with systems in our environment. So one of our biggest lessons is the importance of a human-centered design approach, and acknowledging these human factors and accommodating them in the actual design. So what do I mean by this concept of human-centered design? Really talks to design technology or systems or EMRs around the way people actually work and think, rather than forcing them to adapt to the technology. It's not always easy, and we don't always do it perfectly, but at least being aware of it then becomes important. When you build a new form or process, engaging with the actual end users to test it and give you feedback to see, will it work in reality? And so many times we've been caught out that something that we designed which didn't actually work as well in practice. And once you have an appreciation for these aspects, you can cater for in your design, you can cater for in your training and how you implement. There won't always be a one size fits all, but in most of your critical workflows, if you keep it simple enough, you keep it very repetitive, standardized, structured, users will then develop these simple pattern-driven habits that allow them to embed these actions in their motor memory, and they don't even think about it as they do it. And you try and guide them through those steps, which leads me perfectly into my next point, and that's around nudges. So I alluded earlier to nudges in the concept of CDS and where technology can play a role. But this is a concept that I'm sure a few of you are familiar with, and it's borrowed from behavioral economics. And nudge means structuring the choices in a way that inclines users or people toward a desired action, what we're hoping to achieve, without necessarily forcing them to do it. It's a more subtle way of guiding them to what you want them to do. And in our EMR, we'll use those nudges to promote best practices. So this ranges from simple things like just changing the order of menu options in a drop-down menu, or prioritizing the most cost-effective drugs or search results when they're choosing a medication to prescribe. But yet again, there's always a careful balance to strike in how you implement these nudges. Too many nudges, and users will feel constricted, and they'll even feel that inappropriate influence, or too many notifications and pop-ups, and they get alert fatigue, and at which point then they just ignore whatever you show them, and they don't even read what's on the screen. But ultimately, these nudges aren't there to replace your decision making. It's just there to guide you. And the best designed nudges need to consider the human part of it, acknowledging our biases, our subconscious preferences, and using it to create the best possible user experience. If you then progress from nudges, though, you can go on to simply actually performing the action for the user. And this is where automation plays a role. And automation really trying to automate the mundane, redundant tasks. And this is a beauty and a gift of digital systems. There's so many repetitive tasks in healthcare that we don't require any thinking. For a nurse, when we looked at it in our environment, 50% of a nurse's day is spent on administrative tasks. Things like looking at a screen and writing down a number, writing down the heart rate and the BP. Those are things that add no value clinically. So if you can automate it, you can immediately free up that time, free up the cognitive load, and shift that time back to the tasks and activities that really matter. The unintended consequence of this, and perhaps over-automation in some senses, is that what we learn quickly is that by automating the vitals and the capture of them, we reduce the workload, but we created a gap in that now nurses weren't interpreting the vitals like they used to. When they would write down a blood pressure of 180 over 120, they would immediately have a red flag go up. When you don't do that actively, it's very easy to miss those things. So we have to train our users on paying attention to that and intentionally reviewing vitals as they were being captured automatically by the system, and developing the habits around that. And then ultimately, all of this really comes back down to the core of the discussion is the human being and the human touch. And what we've seen, and all of us are aware of this, is as technology has become more embedded in our society and our day-to-day lives with our smartphones and everything around us, we've all become increasingly aware of technology and how much time and how much screen time we have in our day-to-day lives. So this is not to say that we're doing well to combat it, but at least we're aware of it. And we're certainly more aware of it than what we were 5 to 10 years ago. So then how do we actually proactively combat and tackle it? And for me, the single most important factor, and really coming back to that human aspect, is a core of communication, interaction, connection between individuals. Yes, you can capture everything on the EMR, you can document it, but nothing will ever replace that communication between people, between a clinician, between a nurse, between a doctor and a patient. Nothing replaces that. They can do away with that. And this Could just be your normal face-to-face interactions at the bedside. But even things like a phone call, or a WhatsApp message or a voice note, that personal element to it is so critical in terms of how you engage with people. In the early years, and even sometimes now, people used to say, well, I did it on Care it's done. Everything's there on the system. And it might just be it's abnormal blood results or elevated blood pressure seen by a nurse, or maybe there's an urgent consult or a stat dose. They did what was needed of them from the system, but they left out the human part. And ultimately, all that happened is patients suffered because the right person wasn't informed at the right time. So we have to intentionally and really consciously try to preserve this culture to ensure that technology is there to support the collaboration and doesn't force us to do away with it, and it doesn't replace that human interaction. And this extends equally on the patient side, because we can very quickly, very easily become distracted with the technology in front of us, with the device, with the iPad. We don't make eye contact, we don't engage with the patients, and that iPad then becomes a barrier to us. And look, we even developing a course on trying to support users on how to make better eye contact and engage. And it's not easy, it has to be intentional. But the two tips, the one thing is that on paper, you tend to narrate what's more apparent what you're doing, but on the EMR, for all a patient knows, you could be playing Candy Crush. So simply just saying, okay, I'm reviewing your blood results, I'm reviewing your prescription, and talking to the patient as you work through the steps helps them to feel part of what's happening. But the one added advantage here is that you can also make the patient part of the interaction. You can show them their CT scan or their blood results. You can look at their vitals and their trend, and you can show it to them right there at the bedside on the iPad, and they can engage with the information with you. You can empower them with that information and make them an active participant in that journey. And that's what's so critically important. And then just the last point I want to mention around the human touch is it's also important to have that human touch when it comes to the implementation. Having empathy and patience for each of the people that are on this journey, this transition into an EMR. Some of them will do it easily, and that learning curve is very gradual, or not gradual, it's very easily tackled by them. Whereas others find it far more stressful and frustrating. They need much more support, and it might take them even 6 months to get vaguely comfortable. And what's important that you appreciate this difference in each of the users, and you support them on that journey so that you don't leave anybody behind. And really just summarize all of that is that the humanity in this process really is our strength, and how we incorporate that into the systems. That's where we'll get the full benefit of what these systems have to offer. Okay, I think I might be over time, but I think I've covered all of the aspects and just the four themes. As I mentioned, a comprehensive digital patient record, how it's reshaped the healthcare we deliver, how we can now deliver safer, more efficient care, accessing instant and accurate information. But obviously, with each of these, there's always the balancing act, is that there is a boundary to respect. The convenience carries responsibility of how we protect the information of patients. We have digital tools and a new way of work and clinical decision support, but we need to be aware of how we use these technologies. They don't compromise our own clinical autonomy. They're not there to replace us. They're there to support us. And then transparency and accountability. It supports us, and it's there to aid us ultimately. It protects us medically, and it helps to ensure the integrity of the record. It may seem intimidating, but ultimately, if we embrace it with the right culture and trust, it really adds value. And then lastly, like I focused on now, is that human factor, which is so critically important. The human-centered design, the nudges, automating the routine tasks, and obviously above all, just maintaining that human interaction and building those connections and the communication between each of us. But I think that brings me to an end. Thank you for giving your time this afternoon, and I hope that was beneficial. Thank you, Zianda.
Thank you very much, Dr. Matthews. There are a couple of questions for you in the chat. Please, will you answer them in the chat? I'm just going to ask you one question, which just keeps on coming up, is how do we avoid being hacked? I think that's what most doctors are most concerned about.
Look, it's something that keeps us up at night. It's one of those things that you have to always worry about. Healthcare as a whole is seen one of the fastest rises of cybersecurity events or incidents. So something we give a lot of attention to. There's no perfect solution. It's about ensuring that you pay, that you put the right effort into it. We have firewalls in place. We have encryption. We have protections on users, multi-factor authentication. And you can always implement controls, but you also have to encourage the users around it. You have to build a culture around cybersecurity, because it just takes one person to click the wrong link or to share their password and it compromises the whole system. So there's not a single silver bullet. It's about a journey for all of us to go along, so that we all build a culture around cybersecurity and being aware of it. But yeah, let's say we spend a very significant amount of money and resources to protect our system, and we certainly hope that it's enough, and only time will tell.
Awesome. Thank you very much. Please do answer in the chat.
Yeah,
I think all the colleagues would appreciate your answers. Unfortunately, we don't have enough time. I'm going to move on then to the next presenter, Prof. Ruben Pillay, who is a globally recognized expert in healthcare innovation and a pioneer in leveraging artificial intelligence to revolutionize the future of healthcare. With a unique blend of clinical expertise, academic rigor, and entrepreneurial insights, Prof. Pillay has dedicated his career to advancing transformative solutions to enhance patient outcomes, optimize healthcare delivery, and promote sustainability. I'm not going to go through his very impressive bio. I'm going to just allow him to present to us, and you will get to experience him instead of hearing me read out his bio. Over to you, Prof. Pillay.
Thank you so much. Thank you so much, Zianda. And obviously, I think one of the first things I need to do is work on my tech skills myself. We're trying to get connected with Zoom, but because of, as a previous speaker said, there's firewalls built around everything we do. And I'm sitting here at the UAB healthcare system. And I guess that's one of the reasons that makes it very, very difficult to be able to do the presentation that I want to do. Having said that, I did put together some slides, and I'm hoping I'd be able to share that with you. I have about 30 minutes with you, 35 minutes. I know there are over 620 people on the call, but I want you to try and, instead of just being a passive audience, feel free to, not just put your questions in the chat, but raise your hands. There's no way I'm going to be able to do justice to the whole field of artificial intelligence in medicine or in healthcare, but I think we can get started on the pathway. That was a good first presentation. As Zianda said, I'm based at the University of Alabama at Birmingham, where I head up their innovation, the de facto chief AI officer as well. We also run one of the world's largest academic training programs in AI and medicine. So we've been doing this for a bit. I am a bit more radical in my thinking in terms of the potential for AI to resolve the challenges that we face in health and healthcare. I personally think that we have never been better positioned to solve all the challenges we face in health and healthcare. Now, the issues we talk about today, cost, quality, access, issues related to staff, and issues related to patient experience, are the same issues we've been speaking about since the time I qualified in 1987, and I'm sure the same with you. So, the time is upon us to adopt a more radical approach to what I think is the technology we've all been waiting for years. Sometimes you get this, if you hang in there long enough, you'll collide with the ideal solution that will help you resolve all of the issues that we face. So, I look at the role of AI in the light of that transformative capability. So what I wanted to talk to you about today is just give you nuts and bolts of artificial intelligence. And by the way, there's nothing artificial about this intelligence. Nothing. So it's a misnomer, okay? What we really have at the moment is what I prefer to call computational intelligence. That's what we have. Because that, I think, more correctly summarizes what we're really dealing with. Having said that, the common, AI is used as the common phrase. So we'll for the purposes of this discussion, we'll stick with that. One of the big challenges about understanding this technology and every other technology that we have the benefit of in healthcare is we're very unique in this profession, in the sense that we never are able to maximize the benefit and impact of any technology when we introduce it into healthcare. Think about this. Every technology we introduce into healthcare, access goes down and costs go up. Generally, staff experience, meaning providers, nurses, that tends to go down, and patient experience tends to go down. So we're pretty unique. Any other industry, any other sector, when they actually have embraced technology, it becomes really, really transformative. And I think that's the key issue we have to grapple with first in healthcare. We're notorious for not leveraging technology to improve productivity. The reason each one of us on this call has, well, firstly, we're on this call, meaning we have access to computing. Some of you are probably on your smartphone. Most of you have more than 2 or 3 phones in your household. Most of you have more than 2 vehicles in your household. That's a reflection of industries that have capitalized on technology, amongst others, robotics, to actually transform their industry, okay? To the extent that they have made their products and services available to you is a reflection of how successful they're able to leverage technology. So I want to kind of put that out there because that's a really critical barrier that we have to cross in health and healthcare, that technology does not translate. And we have to focus as much on why is it as an industry and a profession we struggle to translate technology into outcomes as opposed to focusing on the technology itself. And, I think there's an old African proverb that I always use, and I think it really summarizes our profession. And it goes something along the lines of, if a cat wants to become a lion, it has to give up its appetite for rats. That's the kind of question we're faced with now. Do we want this profession to become lions? Then we have to forget everything that we do at the moment and radically rethink medicine and healthcare. We have to radically rethink the definition of who a patient is. We have to radically rethink the definition of who a physician is. We have to radically rethink the way healthcare is paid for. Okay? That's the only way we're really going to benefit from this tremendous potential that AI presents with us. And I say that, not as an overestimation, but I think as an underestimation. So what I want to kind of go into now very briefly is give you a 101 in terms of artificial intelligence, just spend a few minutes in that, and then perhaps take you through some of the transformations that I see that AI is going to drive in the future. Now, I have some slides up front. A lot of it I'm not able to, to share with you because of the issues that I'm facing with my connection here at the moment. So let me kind of go, let's see. Okay, I'm assuming you guys can see that, okay? So, the question is, why do we really need AI for healthcare? Now, some of the issues that I raised with you at the moment in terms of the performance, But the reality is that
I'm
we are.
sorry, Prof. Sorry for interrupting. Can you maybe just full screen that?
Okay, just 1 minute. Well, at least you can hear me. Is that better?
No, now we see the present side as well.
Uh,
That's
uh,
fine. If you can't do that, then just
Yeah,
leave it as
I
it is.
think so long as you can see the content,
Yeah.
and let's forget the cosmetics for now. Okay, so one of the real issues in healthcare is, as this slide I think says, healthcare is very data rich but insight poor. And that's the big problem currently, and I've always say that, the amount of the information that we use at the point of care is minuscule compared to the amount of data that we actually have about patients. And the estimate is that at the point of care, physicians tend to use about 5% of all the data that we could potentially use. Yeah, throughout my life in practice, I've never thought about using genetic data in trying to arrive at a diagnosis. Let alone using all of the expansive behavioral data that we have, using social determinants of health. So we really, although being data rich, we aren't able to process that kind of information in real time to impact patient care delivery. So we really need an automated approach to synthesize this vast amounts of data. So we have a quantity problem as far as data goes. Now, I'm sure a lot of you in this call are specialists. You probably know that in your discipline alone, there's thousands of peer-reviewed publications a year. There's absolutely no way that you can make a lot of or any sense of all of that information and bring that to bear. It's just humanly impossible. We don't have that ability to process information at that level. So we have a quantity problem and a processing problem, which is a human constraint. We also have a quality problem of data. We have a lot of research being done, and the overwhelming majority of that research that is peer-reviewed and that apparently should be shaping our practice is most likely to be false than true. Okay, it's a pretty scary statement, but that's absolutely true. So 90% of all of the research that we're familiar with, ultimately they're based on correlation and associations. And you can argue that correlations and associations are not causation. So that's the big issue. And can we use AI to convert those thousands and thousands of correlation and association studies into causation? Okay, we're able to do that. So this is the reason that we really need artificial intelligence. We're data rich, we're insight poor, and AI is going to help us achieve that. Now, this is a reflection of the amount of data that a single patient produces per year. Okay, it's pretty scary. It's pretty phenomenal. And, there's absolutely no way that we can leverage all of this. Now, I know in the context of South Africa, not all of the data is digitized. They're all in siloed. Well, that's not a unique problem to South Africa, okay? We have that problem in the US and globally as well. So, tons of data available. We're not able to make sense of that. And of course, they come in different shapes and forms. And the term we use for that is multimodal. So, they're out there. We have numbers, categorical data that describe patient types, time series over longitudinal text, et cetera, et cetera. So data is in many different forms. And with AI, we're able to, to make sense of data in multimodal form. Now, as I said, I think the term AI is somewhat of a misnomer. It's computational AI is a better description of this. But the term AI is it's a catch-all term, and essentially describes the ability of computers to think like humans. Okay, for now. And that's kind of the broad category. So it's used very broadly. And there are different levels of artificial intelligence, okay? What we have today is called artificial narrow intelligence. It's very narrow in the sense that AI solutions can only do one thing, for lack of a better term, okay? So if you have an AI solution or an algorithm that can interpret or a chest X-ray, the only thing it's going to do is pick out what it's trained to do. Okay, so you train an algorithm to identify tuberculosis. That's what it's going to do. Don't expect it to then start picking up benign or metastatic nodules or whatever that is. So it's very, very narrow. Okay, the next phase is artificial general intelligence. Artificial general intelligence, we haven't got there yet. And it's a guess in terms of when we'll get there. But essentially, when we speak of AGI, we're talking about artificial intelligence having the same capacity and capability of humans. Okay. Now, depending on who you speak to, some people think we are there. Some people think we're pretty close. Okay. I think we're pretty close, and I think within the next 2 to 5 years, we will have AGI. And that's kind of, called a singularity. That's when machine intelligence starts intersecting with humans. And we're going to have to face challenges that the human species have never experienced before. And then we have artificial superintelligence. Okay, I think we're about a decade away from that. And that's where machine intelligence supersedes human intelligence. Okay, I really think that's the scary, part of AI. Humans have never actually coexisted with anything that has been more intelligent than they have. And I think we're about a decade away from that. And the question we have to ask then is, what's in it for computing to work with us? Think about this. I mean, it's a real question that we're starting to grapple with and starting to answer is, will there be any logic or rationale for computers to partner with sub-intelligent humans? Okay, so I'm going to leave it out there, but it's something that we're going to have to think about. Just a couple of slides there. Let's go. I mean, this goes back way. AI is nothing new. The first time the term was used was way back in 1956 by John McCarthy. They convened a conference in Dartmouth University, and this was the first time that the term was actually used. So it's got a long history, and it's not just recent. And the inspiration of AI, ironically, has got anatomical and medical origins. They kind of conceptualized this by thinking through how the human brain works. So if you go back to the late 50s, early 60s, we had a very basic understanding of how the brain works. And that's another subject for discussion in terms of the progress. But the first kind of AI solution was based on that. And that was called the perceptron. And the perceptron was a mechanical / computerized replication of a neuron. Okay, that's exactly what it was. And you can see if you go back, it looked pretty scary, but that's the origins. The origins was called a perceptron, was designed to process information the way neurons work, and essentially, an understanding of that gives you an understanding of how of AI works. So we have different types, as I said. We have artificial intelligence being the big category. And within that, there's a subdomain called machine learning. And essentially, machine learning is based on, let me just go back here. It's actually based on teaching computers to see patterns. Okay, that's machine learning. So, we take an X-ray. Let's assume the patient has got a nodule. We label the X-ray. So, in terms of density, echogenicity, etc., opacity, etc. And I say these are the characteristics of the nodule. That's labeling. Okay, and then we train the computer based on labeled data to identify nodules. And then what we do, we then test it with unlabeled data. Then we give it an X-ray that's got no labels. And when it reaches the point that it can actually identify the nodule in an unlabeled X-ray, then the claim is made that the algorithm is developed. So that's machine learning. We're actually training the machine. Okay, so it's pretty labor intensive to train them, because you kind of have to label all the data out there, feed millions of these data points into a algorithm or computer, so that it learns, and then start feeding unlabeled, so it can identify the difference. I hope this kind of graphic simplifies it. Okay, so we label what is this, like an ox. What is this, an owl, squirrel, fox. We label them, we train them, and then we just put in an image of an owl, squirrel, fox. When the computer is able to differentiate unlabeled, that's termed machine learning. Okay, so I'm not going to go into any more of that. That's the machine learning part. And then, of course, we have the second part, which is a subset of machine learning, called deep learning. Okay, now a lot of current developments around AI are focused on deep learning. So you'll hear terms bandied about like CNNs and deep learning networks, etc. It's all deep learning. How does deep learning work? It actually works, so there's no labeling. It works like the human brain. Okay, if you think about how, as a child you grow up, and how you're able to differentiate with time a cat from a lion. Okay, you have to see a cat many times and a lion many times, and you get these different sensory exposures. Your parents telling you that the cat is safe and the lion is. So you're getting multi-sensory input that then allows you to make decisions. And the brain works in allocating, using a weighting system before you arrive at the conclusion, this is the cat and this is the lion. Okay? Deep learning is exactly the same thing. So we're not labeling any data. We're showing the images of the owl, of the squirrel, and the cat. And, the system learns with time by allocating weights and probabilities to specific features that then differentiates the cat, the squirrel from the owl. Okay, so that's the principle of deep learning. It's a probability-driven model. AI, deep learning, is probability-driven. Okay, so generative AI, which you're all kind of familiar with now, is a subset of deep learning. Also works on probabilities. But the probabilities that deep learning uses are the billions and billions and billions of data sets that it uses. Okay, so if I have to go in to ChatGPT and I put, the cat pees in A, the system is going to go through all those probabilities from all the billions of data points and choose the probability that the following words are, box. And it will suggest the box. So that's what artificial intelligence is all about. So you got to understand that AI is this broad concept. It's more correctly, I think, describes computational intelligence. It's got a long history. Machine learning is a subset of that. Machine learning means we train the model, and deep learning is a subset of machine learning where it uses probabilities. It weights the characteristics, and with experience, it's able to differentiate. Generative AI is a subset of deep AI, and it's the same model, okay, using mostly text. So, these are just examples. We covered that. In terms of solutions out there, this, I think, was 2023. There's about 900 algorithms out there. A lot of these are combination of machine learning and deep learning solutions. You could see the overwhelming majority are in disciplines that are data heavy. Okay, radiology, a lot of imaging technology, a lot of imaging data, cardiology, neurology, a lot of waveform data. So the disciplines that are at the front end of this are disciplines that have a lot of digitized data. So, and I think that's kind of reflected here. So, yeah. So what I'm going to do is kind of stop sharing the screen there. I'm not sure how many minutes more I have, but kind of go into the application side of AI in medicine and healthcare, and then maybe look at some of the organizational things which I think are pretty important. How many minutes do I have, Ziana?
5 more minutes, Prof.
Okay, so let's move very quickly. So AI in healthcare, the applications are pretty multidimensional. Okay, every kind of aspect of health and healthcare lends itself to leveraging artificial intelligence. So we could use it at the population or public health level. Okay, one of the reasons we did so badly during the pandemic is we just didn't have the capacity and capability and integration of data sources to predict the spread of AI or of the virus. We kind of have it now. Think of the Weather Bureau and how they are so able to accurately predict the pathway of a storm. They're able to do it with almost 100% accuracy, okay? And they're able to do that using, a diverse set of data sources in real time to get to decisions. We can do the same thing in public health and in population health. And I think AI is going to lead to what I call precision public health, that we don't, look at public health as being an average-based approach to developing solutions to public health, that we can do this, at the household level. To me, I think that's going to be the future. AI is going to make a massive difference in care delivery at the individual level. So whether you look at diagnostics or prognostics or treatment, AI is going to be able to personalize care delivery and be able to impact every single aspect of the care delivery continuum. We're seeing a lot of work out there in diagnostics. AI can see things we can't see. Today, we can diagnose diabetes from a chest X-ray. Well, not we, the AI. There's absolutely no chance that we can do that, okay? So that's just one example of how transformative this could be. We're seeing AI in drug discovery and medical devices, that we're able to shrink the time for drug discovery from years to weeks. AI can identify a target, it can identify or suggest a molecule and do clinical trials. The record for a drug to go through all those phases is about a month. Okay, it's already done. The company that does it is called In Silico, and the biggest growth area in pharma now is AI drug discovery. So we're seeing that. We're seeing that a lot in medical devices. On the administration and operations side, I think is, really the low-hanging fruit as far as AI applications go. A lot of the money spent on healthcare is on the operations side. ironically, I think a minor part, definitely as far as the US goes, a minor part of the budget is allocated to actually care delivery. So the low-hanging fruit is operations. How can we use AI to improve efficiency of care delivery? How do we improve efficiency in supply chain management? How do we use AI to improve staffing, et cetera, et cetera? So on the operations side is where the real low-hanging fruit is, because on the clinical side, I think we have not yet broached that or reached that level of trust with both patients or providers to start deploying this at scale. So, that's really important. It has applications all across healthcare delivery, irrespective of which aspect you look at. I want to leave with, as I said right up front, we're notorious in healthcare for not translating technology into productivity and outcomes. And it requires not only a conscious, but a concerted strategy to leverage this. And it's going to have implications at the organizational level. So whether you're a one-man practice or you're running Netcare or MediClinic, it's going to require strategizing and development of charters in terms of where and how and what AI to use, and what level of readiness that it's going to take. Yeah, go ahead. Yeah.
No, we didn't say anything, Prof. You can.
Okay, so to me, I think the first step is literacy, developing leadership, developing AI literacy, because that's critical. And I think it's a good start today. So if I have to give you one piece of advice, is become informed. Okay, now do you have to sign up for a master's degree or a PhD in AI? No. There are lots and lots of free solutions out there to give you a working knowledge of AI. You cannot challenge anything about AI in the profession if you don't have a working knowledge of what AI is, what it can do, what it can't do, and what it shouldn't do. So the single bit of advice that I can give you is look for sources of education. I know SAMA is working to make all of those available to you. So I want to encourage you to take advantage of that, become literate, develop a level of knowledge that enables you to participate in a conversation, but more importantly, ask critical questions about artificial intelligence. I really think if we don't leverage AI to transform healthcare and solve the challenges, generations to come are going to hold us responsible for that. We've never been better positioned, okay? And it really is up to us to leverage this. So I'll leave it there. I'm happy to take questions either on the chat, but I'd really prefer it if you ask me if there's time.
Thank you very much, Prof. I think for me, we've got registrars, we've got consultants on the call, and we know that AI is being used in the academic space. We know it. And I think we are all just, we're just not comfortable with, with the truth of it. So you said the first bit of advice you would give is be informed.
Yeah.
But considering the fact that already registrars are tapping into these AI tools, what would be your advice to the consultants and to the registrars?
Well, I think if you're confident in using it and you're using it to augment, I think you should continue to do it. I mean, in my institute and in my hospital, we even encourage our students to use it. This is, it's technology that's here. And if you can be augmented, why not? I mean, it's, it should make you more productive. It makes me more productive in my role.
Absolutely.
So it's like, well, there's no need to waste time on petty things anymore. You can bring this stuff up. Knowledge now is democratized. It's available everywhere. It's on tap. If you're using a large language model like DeepSeek or GPT or Prepare, whatever you're using at the bedside, it's going to make sense a lot of that information that's already out there. So the key skill you need is what prompts do I actually use about my patient to give me that information? You could photograph if you're doing a ward round and you have no digital data, you don't have an iPad. You can photograph the patient's records and results and engage in a discourse with the GPT. You don't have to follow it, but it's going to be far better than having two other people contributing on the ward round. So even the education and disruption and the way we practice medicine is going to have to change. I mean, it's, as I said, if you want to become a lion, you're going to give up your appetite for rats. We're notorious for sticking to rats.
Yeah. I've got it. I'm going to ask you two more questions, then you
Yeah,
can
go ahead.
perhaps respond on the chat for the rest. There is this anxiety about, clinicians getting potential litigation. So how do you prevent or protect clinicians from that? And then the other question is about considering the fact that we've got unemployed doctors in South Africa.
Right.
What is the next best opportunity for these young doctors to build AI products for the South African market?
Yeah, two really good
So
questions.
could you just deal with those two? Yeah.
I think the litigation stuff is a reality. You have to use it cautiously and use it as augmentation. I also don't think you're going to be too far from litigation for not using AI. Okay, so let's assume that I have a condition X and the doctors didn't have it in my differential diagnosis or didn't diagnose me correctly. Do I have a case to litigate because the doctor didn't use AI? He didn't feed all the information that he had into an AI, whether it's a generative AI or whatever, to get a diagnosis. So it can cut both ways. Okay, so bear that in mind. That will happen. In terms of, the unemployed doctors in South Africa, absolutely, it's a chaotic situation, but that's where the opportunity is. Sometimes it takes an external shock to transform individuals' lives and a sector and a profession as a whole. That's where we are now. And I think it's a fantastic opportunity for these unemployed doctors. They have skills that startups are looking for, that they're, I think, ideally positioned to capitalize on the opportunity. It is a stressful situation for them, but I think what it takes is a mindset shift that you could be far more productive than a traditional physician if you embrace AI. And there's a host of different ways in which you could get involved in this. Remember, when AI becomes, we don't even talk about it anymore and it's part of practice, there's going to be a bigger industry around the servicing of these things. And these are the guys who are going to be best positioned because they have that domain expertise that everybody needs to develop these solutions, deploy them, test them, and validate them. Okay.
Thank you.
So it's going to create a new ecosystem. They're going to be the best positioned, but you've got to see the opportunity. And I'm not sure if any one of them are in this call, but to me, as scary as this time is for you, it's a fantastic opportunity to repurpose.
Yeah. No, thank you very much, Prof. I think we're going to invite you again for another session, and you can delve deeper, into some of it, maybe show us practical,
Absolutely.
tools and ways in which, these, collation of the clinical studies, the shrinking of the drug development processes, how that works, right?
Absolutely.
So we really appreciate you. Thank you so much. We know that you're on the other side of the world. Please, would you just respond to the questions on the chat? We'll be forever
I'll do
grateful.
that. Thank you so much.
Prof.
Thank you.
Thank
Bye-bye.
you.
Bye.
We're going to move on then to the next speaker, who is our very own Dr. Mhlengi Ncube. He is the head of health policy and research at the South African Medical Association. He holds a PhD in public health. So Mhlengi, over to you.
Thank you so much, Sianda. Thank you so much, Sianda. I'll be presenting to you, colleagues, good afternoon, on healthcare policies for the future in South Africa. So this presentation is really going to be quite broad in its scope, and I hope at the end of the conversation, you will be able to indicate on some of the issues that you would want to be addressed in greater depth in future. So I'll start off maybe with just looking at what are the goals of our current health policies in South Africa, and indeed the goals are the same globally. So one of the things that we're really trying to look at across the board is improving access to healthcare. And often when we think of access to healthcare, we think in terms of the rural populations. However, it is not just the rural populations who are underserved. So questions we need to ask ourselves, which we ask ourselves as we deal with access to healthcare, are questions such as, is the Baragwanath Hospital sufficient to serve all the people of Soweto and the surroundings that it serves? Because it is such questions that help us to ensure that everyone, whether in the urban setting or in the rural setting, has access to healthcare. There's also issues related to access to healthcare, of quality of healthcare. So often, when there's insufficient access to healthcare, the quality also declines for several reasons. One of the reasons could be that as healthcare professionals try to ensure that they grant everyone access to healthcare, they then have to also limit the time that they spend with each patient, and therefore limit the quality of care, the time, the possibility to fully assess patients clinically is drastically reduced. And then what we are commonly used to is the issue of equity, which is constantly being discussed. So for those of us who have really, and I think it's most of us who have really interacted with the rural hospitals, we find that patients often have to travel several kilometers in order to get to healthcare establishments. And in some cases, even in those hospitals, there is insufficient expertise to assist them. So they end up being referred again, taking us back to our access story, to hospitals that are far away from home. I mean, when you go to hospitals such as Steve Biko in the morning, you find there's ambulances from the northwest, from Mpumalanga, and the surroundings, and that shows the amount of health inequity that we have in the country, to a point that people have to leave their provinces to come to Gauteng in order to seek healthcare. And very important is the driving down of healthcare costs. I mean, we all, as when we step out of our shoes as healthcare professionals and really look at ourselves during the times that we're patients, think of the cost of seeking healthcare. So our medical schemes have become very expensive. The contributions have become very expensive, and so you find even there's now discussions of low-cost benefit options, etc. All that being indications of how expensive healthcare has become, and vis-a-vis going to the public sector that often is understaffed and faces the challenges that have been mentioned earlier. So our policies then are going to look at quite a few things. So one of the key issues that we look at in the healthcare sector today is human resources for health. And this is critical, not because I'm talking to you, of course, but because it is the human resources for health that contribute more than any other category in the healthcare space to ensuring the health and well-being of citizens. So it is the human resources for health that drive our healthcare system. And so whenever you have insufficient human resources, you are more than certain that all aspects of all quality measures in the healthcare system are actually going to fall. So it is important that human resources for health are carefully managed. And currently, we do have the Global Human Resources for Health Strategy 2030 that was issued, that was prepared by the WHO. South Africa has looked at that and also produced a contextualized Human Resources for Health South Africa 2030 that seeks to address a lot of the issues that, such as clinical staff shortages in our healthcare system. However, we are very much aware that a lot of the problems emanate from inefficient or inadequate workforce planning and distribution. So we do need in our healthcare policies, and this is what we're really looking at, to start looking in terms of workforce intelligence and workforce planning to say how do we gather all the data, the information, the intel about what's going on around the healthcare systems in our country, in our neighboring countries, and of course in the rest of the world, in order to improve our own workforce planning and our distribution of healthcare workers. Critical in our discussions, really, and in our policy discussions is the retention of the healthcare workforce. I mean, I, for one, can count a number of my friends that have left and are practicing either in the UK, in the UAE, or in Australia and New Zealand. So I think even as far as recently, I tried calling a friend and he told me, "Oh, dude, I moved to New Zealand a few weeks ago." And so this is our reality that we are struggling to retain our healthcare workforce. And this is really in all categories, whether it's be the allied health professionals, it be our nurses, or it be medical doctors. As a matter of fact, one of the hospitals in Saudi Arabia has one of their chief specialists hails from the Free State. And it wouldn't be surprising that there's some hospitals in the Free State that desperately need his services, but unfortunately, we did not retain him, and so he's over there. We also need to consider, strategic deployment to rural and underdeserved areas, and this is particularly important, I think, to us when we think of where many of us come from, where the healthcare services have been inadequate and the areas have been severely underserved. However, there is a policy discussion in other sectors of healthcare that seeks to abandon community service for several reasons. And so we need to look when addressing those policies to then look at how, when we replace certain policies with others, should it eventually get there, how do we ensure that whatever policy replaces the other does not then create an environment where some areas continue to be underserved and that there is poor deployment of our healthcare workforce in the rural setting. So it is important to us as SAMA, but I think it is really a moral imperative that we do think of the poorer communities and those that are underserved. And of course, part of our workforce planning will include improved training programs. We have, tried to improve the number of students getting into medical school, but clearly there is the struggle of getting them to work post community service, which again speaks to the workforce planning that we do have. And eventually, what we're going to see is even those students or those medical graduates that we've trained in the country, will again leave because we failed to provide them jobs with jobs, and we will, and then we still get on to fail to retain them. And there is other countries. I mean, the UK and the USA will be the chief culprits that will take a medical graduate from anywhere in the world, and they get to do their internship there, they get licensed there, and so the return on investment that we've done in providing bursaries and in providing subsidized medical education then provides benefits to other countries outside South Africa. So a lot of policy work really that we're going to see emanating from both SAMA as well as other stakeholders is going to really center around human resources for health and how we're going to do our workforce planning, and more importantly, the creation of opportunities for the unemployed doctors and other healthcare workers, as well as ensuring that we do retain our healthcare workforce. Related to the healthcare workforce is going to be the safety of healthcare workers. I'm sure all of us colleagues know of a colleague that has been a victim of crime. At times, even they being targeted because of the profession, and this happens both in the private and the public sector. We have had doctors being killed in their practices, and one will not make.
It looks like we have lost Dr. Mhlengi Ncube temporarily. We'll just allow him to join. Colleagues, if you have any questions, you can post them in the group in the meantime. Yes, Asbonelo?
Dr. Mhlengi advised that he's having network issues, but he's sorting that out to join.
No problem. Thank you for that. You can just project the program in the meantime, Smonelo, for us, so that we can just show the colleagues how far we are. After Dr. Ncube's presentation, we are going to have Dr. Harbour, who will share with us some of the work that they are doing with the South African Registrars Association. So I don't see any questions thus far in the chat. So can I check, Dr. Harbour, would you like to perhaps give us the update from Sarah while we try and reconnect Dr. Ncube? Over to you, Dr. Harbour.
Certainly, Ziyanda, thank you.
Thank you.
Good evening, colleagues. My name is Dr. Sharon Harbour, and I'm the chairperson of the South African Registrars Association. I am very grateful for this opportunity to give you a brief update about the work that Sarah is doing, and hopefully entice you to come and become part of our committee in the next few weeks. So essentially, SARA, as a lot of you know, stands for the South African Registrars Association. And our main purpose is to promote the interests, both academic and professional, of registrars in South Africa. And a lot of times we do this by representing the interests of registrars in various bodies. I think as a medical fraternity, we're all aware that the position of a registrar is a unique one, in the sense that you're accountable to both the National Department of Health, or be it NHLS, but you're also accountable to your university, you're accountable to the CMSA, you are accountable to the HPCSA, for example. And what we found as the South African Registrars Association is a lot of times actually, is that those different entities may not necessarily speak to each other. So our role essentially is to serve as the intermediaries between these different responsibilities in order to make sure that your interests have been heard. So over the last year, a lot of things that we've been doing has been just for that. A big win for us last year was we hosted our very first registrar's writing retreat. And this emanated from a study that we did earlier in the year, where we found that a number of registrars were struggling to complete the research component for their MEd. There were various reasons why. But based on the findings from our survey, we realized that what was critical was also having registrars. So it was also registrars having access to certain specialists that they need in order to complete this portion of their research. And so we held a retreat where registrars were invited and they had access to our statisticians, writing specialists, editors, people who are also involved in publishing. And this was to make sure that registrars were given the best chance to complete their research. A lot of other things we do is, if you're a registrar, you know that work-based assessment is around the corner. And so we sit as part of the executive committee in order to make sure that, hey, the registrar's perspective is also considered when big changes will be done. We've represented registrars on various occasions, be it with the CMSA or be it with the HPCSA. And another win about 2 years ago was our ability to support a group of registrars as we aim to make sure that registrars within the NHLS receive their pay progression. So there are a lot of things we do. Last year has been busy, but I think my main call is to say that within the next few weeks, we're going to be having adverts for anyone who's interested in becoming or forming part of our committee. We're looking for registrars who want to make sure that the interests of their discipline, but also the interests of the university is heard. And so if you are such a registrar, please be on the lookout. So within the next few weeks, we will be approaching you, we will be advertising, and we'd love to hear from you. I think we're only as strong as the diversity of feedback that we receive. So if we're able to receive enough feedback from different universities and different disciplines, we're able to ensure that registrars are, as a whole, are accounted for. Thank you so much, Ziande, for the opportunity.
Thank you very much, Dr. Harbour. Dr. Mhlengi is back, so I'm going to allow him to complete his presentation, and then we'll take a short Q&A, and then I'll officially hand over to you to facilitate the next session. So thank you for your responsiveness. Over to you, Dr. Ncube.
Thank you, and apologies for my Wi-Fi. Linked to the human resources for health is the safety of healthcare workers. And we are aware we have lost many of our colleagues to crime, both in the public sector and in the private sector. We've had doctors being gunned down in their practices. We've had doctors being hijacked at hospitals. We've had doctors being robbed in hospitals. There is a lot of issues that have safety breaches that have occurred in the hospital. And when we look at it, some of the cases really have emanated from the regular crime by criminals that will be seeking economic benefit. However, in some cases, some of the violence really has been from patients, and it's been really difficult to prevent some of the crimes because the security guards may not be adequately trained to deal with the kind of security to manage the kind of security that they are able to provide, that they're supposed to provide. And in some cases, this has been linked really to, especially where patients are involved, it's been limited to the consequences of inadequate staffing ratios, as well as the consequences of burnout and medical errors, where patients become frustrated with either long queues, delayed care, or poor clinical outcomes. And a lot of times, as aforementioned, it has to do with adequate staffing ratios, where the doctors become overstretched and they can't see certain patients on time. and due to burnout and fatigue might not be able might not be humanly able to perform certain tasks to the efficiency and quality that they are able to. And so there's also issues relating to mental health that emanate from some of the consequences of this crime and experiencing and actually witnessing some of these incidents happening to colleagues. We do have challenges in our hospitals of infrastructure that promotes or enables criminal behavior from some elements. So, for example, there are areas that have poor lighting, and when healthcare workers are working at night, then they have to pass through those areas. Some are very dark and isolated, and so opportunistic criminals are able to take advantage of those settings and commit crime and harm our colleagues. And so as SAMA, we have done some research that really showed that these crimes are spread out across the country with Gauteng, KZN, and the Western Cape being the worst affected provinces. And we have drafted up a policy brief that we intend to engage with different stakeholders, so that we're able to come up with solutions that doctors and other stakeholders are comfortable with and are confident that will enable their security and as well, solutions that we can share with the different stakeholders, such as Department of Health, as well as the police commissioners, so that they're able to protect our healthcare workers better and understand the dynamics around our working environment, where at times people have to work shifts and travel or be in places when there is very few able-bodied people and witnesses to protect them or share in the community protection that is afforded to citizens during normal working hours. And so we are going to see a lot in the future, discussions on the safety of healthcare workers, on different platforms, as well as between different stakeholders, so that we ensure that all our colleagues are protected and are not targeted because of the noble profession that we are in. So something that we learned from COVID-19 has been how the shortage of medicine is actually frustrating to doctors, and actually makes healthcare workers even feel they have to play God in terms of making decisions about who can and who cannot get certain interventions. And this really has profound mental health effects on doctors as they try to make decisions that they shouldn't be making in the first place. So we are going to see more policies particularly from the ministry space addressing chronic shortages of essential medicines. So there is currently a ministerial stakeholder consultative forum that is trying to deal with this, and one gets to learn from that forum that the challenges that we have in some of the provinces, as well as for some medications, is actually very profound, and there is need for us to improve our procurement policies in order to deal with access, with the actual availability of medicines. So we do need to strengthen our supply chains and also deal with other policy issues that at times have gotten certain individuals either excited or feeling they are going to be useful, but might not necessarily be. So one of the things that we very much will see being a stronger discussion in the next coming few possibly months is going to be the issue of IP and how IP affects equitable access to medicines. However, there is need as well for us, when thinking about these policies, to be able to balance out between the importance of IP access and the importance of investments in innovation of health technologies. So, and by the way, for those who haven't worked in SAMA, health technologies includes the medicines as well as other medical devices. So we're going to see a lot of discussions in the healthcare space relating to IP and availability of medicines. Also critical, we have seen is corruption in the healthcare sector. And it's no wonder there is actually a special unit that is part of there's actually the anti-corruption in the healthcare sector forum that is specifically designed to deal with corruption in the healthcare sector. And so with that corruption, money is lost, and the money that was meant to ensure availability of our medicines also gets lost in that aspect. So we do need, just like human resources, careful supply chain planning, careful procurement planning, so that we're able to ensure that we do have better access to medicines, as well as policies that are going to encourage better access to medicines and make sure that our medicine availability is very much equitable, and we don't find ourselves, especially finding the good medications being a preserve of the private sector patients while leaving our public sector patients out. So it is, though, encouraging that when one interacts with some of the specialists, they have been very keen on ensuring that when in the event of being dually employed, whatever they purchase or recommend for purchase for the private sector, they do some of them make an effort to ensure that those are the same recommendations that they give to the public sector for procurement. So we will, as mentioned, start hearing in the next few weeks or months some stronger engagements relating to access to availability of medicines, and really much of the conversations that we're going to hear in the very short term are going to be dealing with IP issues and how IP is hindering and can be used, if possible, to ensure that we do have better access to medicines. Then there's infrastructure development. So with infrastructure development, many of us in our hospitals have seen how dilapidated some of the infrastructure is. And so massive renovations are required to ensure that our hospitals are safe, from an occupational safety perspective, and as well as from a quality of healthcare perspective. However, when we start looking at it from the perspective of universal health coverage, which I think our government has been singing the song of NHI, and the law has been signed, etc. So part of making sure that there's universal health coverage, and if ever the NHI were to be successful, one of the main readiness requirements would be investment in healthcare infrastructure. So having worked in places such as Northern KZN, one got to appreciate that several patients had to travel very long hours. I mean, very long distances to access the nearest hospital. I mean, one of my biggest shocks was driving from Dumo village to Mossford Hospital, and to think that Mossford was the hospital that was providing healthcare services to Dumo was utterly unbelievable, given the distance that one had to drive, and also that the hospital was situated on a mountain, and so if one didn't have a car or some reliable mode of transport, it was literally an uphill task to actually access the hospital itself. And so it's some of those infrastructural discussions that we're going to see, especially as the discussions surrounding the NHI get heated up. I mean, presently there is a call for comments on the governance regulations for that, it's showing that there is, some political will to accelerate, certain activities, and as that acceleration is attempted, infrastructure is going to be one of the hindrances to ensuring that whatever desires are required at that point, or whatever goals they seek to achieve, will be difficult to achieve in many areas of the country. Then there's going to be issues of modern medical technology. So technologically we've transformed a lot, and I think we listened to the earlier speakers, Dr. Matthew and Dr. Pil and Prof. Pillay, speak about artificial intelligence. So that's part of the modern medical technology that we are going to start hearing about, from an investment perspective, to say, how do we fit that into our healthcare policies? How do we fit that into our budget policy? And also from an infrastructural perspective, how do we ensure that we're infrastructurally ready for the implementation of such technologies? Still linked to the infrastructure is the issue of water. We are grateful that it's been raining a lot these days, but there are some areas that are still going to struggle with water, and hospitals in some areas do struggle with having adequate water as well as electricity. At least electricity is not that bad these days. However, as we speak of the just energy transition, etc., we need to make sure that we, as much as possible, ensure that our hospitals have enough renewable energy so that they are insulated from any power cuts, and should we have any electricity challenges in the future, we should hope that we're not going to see our hospitals being impacted. So there are in some countries that have been dependent on mining policies that have enabled the mines to actually have their own electricity lines that come directly from the power producers, and so ensure that the mines do not run out of electricity at any point. So if there is only one in quotes generator working, at least that generator is going to ensure the mine works. And I think we should start looking into such policies as well to ensure that we're able to have our hospitals get uninterrupted power, even in instances where the power supply is extremely limited. And so the sustainable practices really will include, those policies, as well as policies relating to renewable energy being used in our healthcare facilities. I mean, it's never incomplete it's never complete without artificial intelligence in this day and age. And so we're going to see a lot more policies on artificial intelligence. Right now, there's a call for comments on AI in healthcare that we are responding to. It's actually AI in healthcare ethical guidelines with the Health Professions Council, and I really would encourage everyone to look at those ethical guidelines and reach out with opinions on what they think the guidelines should look like, because those are guidelines that are going to shape the way that you practice medicine in future. So we did hear Prof. Pillay and Dr. Matthew speak, more from a clinical end on how AI is going to be used. However, AI goes also works in healthcare when it comes to optimizing resource allocation. So much of the medical data that comes through, and it's largely epidemiological data, is going to be able to make us understand that where is the greatest demand for what. So for example, we're going to be able, using AI tools, to predict the areas that have higher populations of chronic patients, where we need to invest a lot more human resources for health, so that those areas are able to deal with the chronicity that is in their environment. So there are also going to be instances of outbreaks that we're going to be able to predict where outbreaks are and be able to move the required resources to those areas. So another another part of the artificial intelligence work that we're going to see and actually has begun is looking at expanding healthcare services to rural areas or remote areas using telemedicine. And some of the telemedicine tools are going to have artificial intelligence embedded into them so that we can improve on our healthcare equity. And so we're going to start seeing again, I mean, there's the booklet 10, I think, that was published in 2001 by the HPCSA on telemedicine. And we're going to probably start seeing a lot of revisions to some of those regulations as telemedicine becomes more widespread, used more widespread in our sector, and we start learning different things about how it is used in a practical sense. And I think Prof. Pillay also mentioned something about AI competencies, which is also going to be key. And we're going to hear more of those AI competencies, whether it's going to be in terms of upskilling healthcare workers at work, or also we're going to start seeing our policymakers at an academic level looking into how AI can be incorporated into the medical curriculum. And so some of those that are thinking of specializing might find those policies having changed and them having to find a bit of AI included in their specializations, because those will be the tools, those are the tools for the future. So there's, of course, to implement a lot of these policies, the main challenge is money.
Dr. Hamilton,
Yes, sir.
We have run out of time. I'm going to give you a minute to wrap up. Over to you.
Okay, thank you. So we need money to implement most of those requirements, including ensuring that we retain our healthcare workers by ensuring that they are well paid and do not need to leave the country in search of a better livelihood. So what can you do as a medical doctor? So as a medical doctor, you need to participate actively in stakeholder engagements on policy issues, because it is your expertise that is required in order to transform potential future healthcare policies. And it is your expertise that is going to help us build policies and advocate for policies that will help us build, an equitable healthcare system. We don't want to leave any South African behind, because all those some of the South Africans that get left behind are our own loved ones, and in some cases could even be us. So it is in our best interest to make sure that we align our national priorities with global health goals, as well as ensure that we participate through SAMA in the health policy development. I think because I was given a minute, I will stop here, and thank you so much. I'll be stopping and caught myself at the end.
Thank you very much. Thank you very much. I'm not going to take questions. I'm just going to ask you to please respond on the chat. We have about 4 questions on the chat. Would really appreciate that.
Okay, thank you.
Colleagues, thank you for the opportunity. I would like to now hand over to Dr. Harbour, who will take you through the last hour of this webinar. Over to you, Dr. Harbour. Thank you.
Good evening again, colleagues. Thank you so much, Dr. Mgugudoselo. You did an excellent job, and I hope to do the same. Colleagues, without any further ado, I'd like to introduce our next speaker for this evening. Our next speaker is Dr. Nondumiso Makunga Stevenson. She is a certified physician, leadership development, and executive coach with over 20 years of diverse experience in healthcare, spanning pharmaceuticals, public health, general practice, and clinical research and hospital management. Her expertise uniquely equips her to understand the challenges of health, the challenges that healthcare leaders face in navigating complex and uncertain environments. She's a passionate advocate for an Ubuntu-centered leadership. Dr. Makunga Stevenson draws on the African philosophy of interconnectedness to help physicians align their personal values with their professional aspirations. Her coaching empowers leaders to resolve conflicts, to enhance productivity, to strengthen team dynamics, and to develop awareness of emotional intelligence. She is deeply committed to guiding healthcare professionals towards purposeful and authentic leadership and having fulfilling careers. Having personally experienced the pressures of healthcare leadership, Dr. Makunga Stevenson transitioned into coaching to continue making a meaningful impact. She collaborates with clients to build transformative strategies that honor both their individual goals and their collective well-being. She believes that every physician can achieve a fulfilling career and life by aligning with their core values and leading with both purpose and authenticity. She holds the distinct honor of being the world's first medical doctor who was trained and certified in Ubuntu coaching. Without any further ado, I'd like to hand over to you, Dr. Makunga Stevenson.
Thank you, Sharon. I'm going to share my screen. You can see that. If you can see that.
While you are busy sharing your screen, I would like the audience to know that I am a first-hand recipient of one of your talks, and so they're in for a big treat this evening.
Great. Thank you. Thank you so much, Doc. I just wanted to check in with you that you can see the screen.
Yes, I can.
Awesome. And it's in presentation mode.
Not yet. Now it is.
Great. Thank you so much. And again, thank you to Sama for inviting me to talk about leadership mistakes. What I wanted to what is maybe special about the fact that Sama did approve this topic was that it actually creates a safe space for us to talk as doctors around the mistakes that we make, but also I will take time to acknowledge some of the reasons why doctors are actually very good leaders. So I'm going to use the word physicians interchangeably with medical doctor. It's actually the same thing. I've moved the slide just to check with you, Sharon, that it's moved to the next slide, yeah?
Correct.
Thank you. So inside, if you are interested in connecting with me, particularly on LinkedIn, you're free to scan the QR code, and that will take you to all my contact information. I won't spend too much time reintroducing myself. Thank you, Sharon, for that. But other than just to emphasize that my passion in this season of my career is to help doctors to design their leadership and their career legacy, which I think is very possible if we allow ourselves and we give ourselves permission to do so. I am the founder of Ubuntu Doctor Coaching, which is a coaching practice where I work with doctors, predominantly through that from South Africa and also other African countries. But I'm also an associate coach with a US-based coaching practice called MD Can Help, where I also support leadership development coaching, mainly for American doctors. With regards to the scope of my talk, what I think is important to outline is that what I'm not going to cover is clinical leadership training. So this is not going to be about improving your clinical decision making or your medical expertise. This is going to be about how to show up as a clinical leader with regards to your leadership role. This is also not going to be a critique of the medical education system, but I will examine how our traditional education and our training does impact on our leadership styles. I'm also not going to offer any quick fixes or hacks, because leadership is a long-term process, and it's not something that gets resolved overnight. What I will cover is some of the psychological and behavioral patterns that can lead doctors to struggle in leadership roles, why these mistakes are important for us to understand specifically as doctors, and how they impact doctors that are in leadership roles in healthcare organizations with regards to expectations, their own expectations, their team's expectations, as well as workplace dynamics. And then I'm also going to take a deep dive into how these mistakes show up in terms of the thoughts, the feelings, and the behaviors around each of these mistakes. But I will also propose some mindset shifts to help you to effectively lead without burning out. And I'm really grateful that particularly Prof. Pillay laid out the importance of the mindset shift. And as a coach, this is really the work that I do, and I have definitely seen the importance of being able to get results just by adopting mindset shifts. So as he said, moving from the cat mindset to becoming the lion that you can be as a leader. So who will benefit from this talk? Firstly, if you're new to leadership, I think you're definitely in the right place. If so, new in roles like medical director or chief or principal medical officer, department heads as well, senior registrars, or anybody that is actually in a leadership role, including in medical associations, student associations, even student leadership. If you're struggling with leadership challenges, which many doctors are, particularly around team dynamics, delegation, and emotional intelligence, but also if you just want to enhance your leadership skills and maybe you are stuck in old patterns of leadership. But many of us find ourselves frustrated with current leadership approaches. And so again, I will propose how to move forward in terms of the mindset shift that you can adopt in order not to continue on the trajectory of making mistakes in your leadership journey. It's not for doctors, I think, who are solely focused on clinical expertise and who don't have any leadership aspirations, or those who don't struggle with leadership areas that I will talk about, or anybody that's looking for a silver bullet. As I mentioned, leadership is a journey, and it's got many twists and turns, so there is no silver bullet or solution that I could certainly propose to you in the time that we have together. So how I've structured my presentation is that I'm going to just introduce the context and the challenges that specifically doctors face in leadership roles and how our medical training shapes our approach to leadership. And I'm also going to set the stage for understanding the mistakes through the lens of the feelings and the thoughts and our behaviors. I will delve into, I've selected just 5 leadership mistakes. These are mistakes that I have made, if that makes anybody feel better. But also these are the most common mistakes that I see coming into the coaching room. And I draw heavily on that to also give a space for self-compassion. The medical field is one that does promote perfectionism, and it's often people don't really want to talk about the struggles in leadership. So I think in sharing the examples and also sharing that these are very much some of my own experiences, perhaps that might allow you to feel that you're not alone. You know, it is not an indication of you as a person or of your competence. And then I'm going to leave you with some key takeaways and reflections. And then I'm also going to offer you a resource that will help you to assess your leadership skills and maybe areas for potential growth. So why are we even talking about this? What's so special about physician leadership? What's the relevance of this? Now, we know that when you give feedback, you have to start off with a sandwich. So you start off with what is good first and what's working, and then you give the mistake, and then you end off with a way of empowering an individual to grow. So I am going to start off with this, and this is substantiated by evidence. So this is widely published. It's not my opinion, although it's also my observation. I'm sure for many of us have experienced and are aware of the value that doctors bring into leadership roles in healthcare organizations. So the one area where doctors are particularly good is around quality improvement. So the evidence does show that the deep understanding of clinical practice and patient care enables us to identify areas of improvement, and we're able to implement strategies that lead to better outcomes. And also, we have a very comprehensive understanding of clinical processes. We understand healthcare team challenges, and we also able to assess policies and initiatives that would serve a patient-centered approach. So this is one of the values that we bring into healthcare leadership. So this we do through our ability to bridge clinical and administrative roles. Physician leaders are also well placed to improve patient satisfaction and higher staff morale. So there is evidence that where you have medical doctors as leaders, healthcare organizations, benefit from patient satisfaction, and they benefit from higher staff morale because doctors are able to effectively guide teams in delivering high quality care. Another aspect or value that doctors bring to leadership roles is around engagement, physician engagement. So evidence does show that doctors in a healthcare organization have better engagement when the leader is a doctor, and it also contributes to reduction in burnout, and job satisfaction is higher when doctors are leading healthcare organizations from other doctors. And then finally, and this might surprise some people, but organizations that are led by physicians demonstrate better financial performance, and they're also better equipped to navigate the complexities of the healthcare system. And this is because we are able to bring the clinical perspective to business decisions. In other words, the allocation of funds and resources can actually support the functioning and the outputs of and productivity of healthcare organizations because of our understanding of the clinical environment and clinical workspaces. So why do physicians struggle? So this is where I said this is the meat now of the sandwich. So I laid it out by saying that you are capable as a doctor. It is possible for you to be an excellent leader. But many doctors find themselves struggling. And these are some of the reasons why they struggle before I get into some of the mistakes. The transition from clinical expertise to leadership is particularly painful, at times even psychologically painful for many doctors, because our training does focus and emphasize hierarchy, protocols, and not necessarily place much emphasis in training us in collaborative and adaptive leadership. And so the key challenges then manifest as difficulties in managing the teams, difficulties in strategic planning. The second area that contributes to why we struggle, and I'm going to spend a little bit of time here because it really gets to the core of the conversations that I have with the doctors that I coach. And just to be clear, I coach doctors from multiple countries. So these are very, very common issues. Please don't feel that, again, it's unique to South African doctors. This is a part of our training and to some extent who we are as doctors. Many doctors strongly identify with clinical roles. So it makes the leadership transition, especially when we have less time or no time in front of the patient, psychologically challenging. We have to adopt a mindset where we are moving from an individual contributor to a team leader. And sometimes that requires a change in identity and transitioning from a clinical role into a strategic role. And our training typically does not provide us with enough tools and resources to have that dual role. So the socialization that we have means that we feel that when we move into a leadership role that takes us away from patients, it feels like a departure from our purpose. For some doctors, their purpose is even tied into their faith. And so moving away from the individual patient focus can sometimes create a lot of discomfort in doctors. And this will manifest in some of the mistakes that I will share shortly. There's also sometimes this heroic individualism that can be ingrained in medical culture where we value doctors who are autonomous, doctors who are direct in their decision-making, as opposed to a collaborative and a team-based leadership approach. And again, that also makes the transition into leadership with that type of mindset. What we normally see in medicine is that doctors who have exhibited clinical excellence, so in other words, they've published and they've done groundbreaking clinical work or medical work, often get promoted into leadership positions. And we often mistake that their clinical excellence will translate into leadership competence, not acknowledging that leadership actually requires additional skills to clinical skills. And we need additional skills for effective leadership. So the soft skills and being mindful and being trained and understanding how to apply soft skills, we often unprepared for when it comes to leadership. How to influence stakeholders, how to manage resistance to change is often not something that we're used to. As I said, stepping away from patient care can also trigger feelings of guilt. People asking themselves, am I still a doctor? Who am I as a doctor with my MBCHB, but not in front of a patient? This mindset is sometimes reinforced by the rewards of clinical work because it can be very rewarding. It's not in every situation where doctors, somebody will say to you on a daily basis, thank you, doctor, you saved my life. This is why we do the work that we do. But once you move into a leadership role that takes you away from patients, you may struggle with not getting that immediate feedback from patients and from clinical work when you're delivering a baby or something like that. Because in organizational leadership, for example, it's more abstract, it's more about achieving long-term organizational goals, which may in the short term be less fulfilling. So you don't get your daily dose thank you, doctor, you saved my life. We also have in the community, and again, I'm sharing this as something that I've found across, irrespective of the country, but where peers may view doctors who move into leadership roles as kind of selling out, if you will, or moving to the dark side. And this I've seen particularly amongst doctors that move to insurance companies, that work in insurance companies, where they may be perceived as betraying the clinical mission. And so that may create some isolation. So these are some of the reasons I think that sort of set the stage for some of the mistakes that we make as doctors. So I'm going to just quickly go through some of these mistakes and how they look. So the first mistake is micromanaging, right? Not delegating. Again, we are trained to take full responsibility for our patient outcomes, coupled with the fact that the medical community is one that prizes, I want to say, or let me say, there's a culture of perfectionism in the medical community. And so there's very little room for error. We reward autonomy. And so adjusting to a leadership role, one definitely has to move out of that mindset where you would say, if I don't do it myself, it won't be done right. And the behaviors that you would see, would be hovering over team members instead of empowering them, taking on too many tasks, burning out in the process, correcting other people's work, redoing their work unnecessarily so, because you're not acknowledging what they are bringing to the table. And so the mindset shift I'd like to offer, if this is you, if you can relate to this, is around reframing delegation as empowerment, as a leader, empowering your team to bring to the fore their strengths, but also perhaps in delegating, they will be able to identify their opportunities for growth and their weaknesses as well. So you can start this off just a little bit at a time instead of holding on, just one small low-risk task that you can share with somebody in your team, and then support them in that until you become more comfortable, and they also become comfortable in executing on larger, more complex tasks. Another way of thinking about delegating is to delegate results rather than delegating the how to do something. So that is a way of ensuring that your team also can build on their own strengths and understand their own strengths. The second mistake is around emotional intelligence. I think these days we hear a lot about leadership and emotional intelligence. And that refers to the textbook definition is the ability to recognize, understand, manage, and influence one's own emotions and those of others. And it also plays a crucial role in your personal and professional success. Some people say more so than your IQ. So emotional intelligence in leadership is a soft skill. And what I've observed also with many of doctors in coaching is that we are trained to be stoic as doctors. And I'm not saying that's a bad thing. We are trained to be stoic. We're trained to be resilient. But there are situations that require for us not to have that level of detachment when we are in leadership roles. And so when we are socialized in that way, it can create a barrier if we don't have self-awareness, and we will then struggle with empathy, and we will struggle with interpersonal communication. So you become dismissive of emotional conversations, you'll be perceived as cold and unapproachable as a leader, and you'll struggle to build strong team relationships which are important for the team to have some level of coherence and unity in order to deliver. Emotional intelligence is now, I think, considered a leadership superpower, as some people say. And one of the ways that you can foster emotional intelligence is to practice self-awareness, have some self-compassion, as I said, but also you can ask for feedback on how you come across. I loved that I am doing my talk after the first two speakers who talked about technology and the importance of technology and how it's disrupting the medical space, because this is also one of the areas that I'm seeing coming up in coaching. The ability or the failure to adapt to change is certainly one that can hold you back as the leader. The medical culture values traditions, right? We are trained in evidence-based approaches, and the evidence approaches generally emphasize stability and reliability. But the healthcare space, especially in the last decade, and certainly since COVID, is evolving very rapidly. It's new technologies, it's policies. The patient expectations are not the same anymore. And so that requires adaptability. And so coming from a clinical setting, it can be difficult for physicians or doctors to become accustomed to a dynamic environment, and they may even resist a dynamic environment because we are coming from a structured environment. So what they will tend to do is to ignore and resist new systems. If AI is introduced, they kind of avoid it. They stick to the outdated practices. And then they may also react negatively to any initiatives that promote change. I had a client who was competing for a leadership role, and she mentioned that younger doctors, and specifically the one doctor that she felt had a strong chance of getting the role, just knew where to find information. And as we started talking about it, we realized that it's because the younger doctor was so much more comfortable with tools like AI. And so they were using these tools to advance their profession and be competitive in the workplace. And so that is the type of mindset that one would have to cultivate. So in this case, it was really, instead of resisting the change to AI because she was emailing the librarian to do searches for her for articles and order books, hard books, she had to adopt a different mindset, where she said, how can this new initiative or this new technology improve patient care and team efficiency? We are seeing also, certainly in the US, more doctors becoming chief information officers and being at the front of the change and leading the change, because they understand how best this new technology can actually support the clinical workflow and support doctors that are working with patients. The patient comes first, always. I think this was drilled into all of us as doctors. And we're conditioned that way to prioritize patient care. And while this is very important, we have seen that many doctors also prioritize patient care over self-care. Depending on the environment that you're in, it's common for burnout to happen because of long hours. Doctors just don't take rest, and we often look at rest as a weakness. And burnout in some contexts is even a kind of like a badge of honor. And how this shows up, you skipping meals, sleep, or exercise, you take on everything, you overcommit, you have no boundaries, and you ignore your personal health until it becomes a crisis. And the mindset shift is really, to use a cliche, you cannot pour from an empty cup. Yes, you want to be there for your patients, you want to be there for your team, but it's not going to be possible to lead effectively if you are burnt out. And so again, setting boundaries, delegating, and normalizing self-care is a very important mindset shift. And then the final mistake that doctors make is underestimating the power of influence. In our structure as doctors, there is a hierarchy, right? So leadership is often associated with seniority or title. So you just only need to look at the title in order to understand the level where the doctor operates and the power and the authority that they carry. And so many doctors don't really understand that it's not only the title that confers leadership, but it's also your expertise as a leader that will command authority, that will assist you to have influence over others in a positive way, and understand that true leadership is about inspiring and mobilizing other people. So how this manifests is relying too much on directives, right? So what I call the doctor's orders mindset. This is what you should do, and that's what should happen. Not communicating a vision and inspiring people to be part of your vision, and connecting with the team for them to be able to support your vision and to support your legacy. So again, the mindset shift here is really understanding that it's about influence. It's not about authority. And that influence is earned. It's not granted by the position alone. And it's important as doctors to be able to build trust and engage your team in decision making. So some takeaways for you as I wrap up is, firstly, understand that leadership can be learned. There's so many available resources, specifically for doctors. There's mentorship, there's coaching, there's even training, degrees and qualifications that one can get that will help you to avoid these mistakes. So it's not inherited. It's also a journey. It's not a destination, as I've said, and it's okay. We are humans. We will make mistakes, and we will learn from those mistakes. That is part of the journey and the beauty of the journey. Adaptability is definitely key to success. We're living in a political climate also that is sometimes difficult to remain rigid in. And so being adaptable as a leader and being able to navigate your team through all these changes that are happening is one of the attributes of a good leader. And then also leadership, as I've said, is built on influence and not title. So if you can take away just those four takeaways, then I'll be more than happy. I promised that I would share a tool. This is a quick quiz that you can scan. It will take about 20 minutes. That will help you to do a self-assessment for yourself, and it will give you a report at the end that will just guide you through some areas potentially that you can develop in leadership if you are interested in doing such. And then I'm going to leave you with a quote by John Maxwell. I think many people are familiar with him and his work around leadership, which says the leader is one who knows the way, goes the way, and shows the way. And so this is really a clarion call to all of us, whether you are doing leadership in any way or form, no matter how small, but certainly for those that are in leadership roles, to be leaders who know the way, who go the way, and also who show the way. And I will end there. Thank you so much.
Thank you, Dr. Makunga Stevenson. And as I thought, once again, you did not disappoint. Thank you so much for that. I've noted some of the questions in the chat, but while maybe we're still waiting for questions, I think a big thing you touched on when we started was the emphasis on perfectionism, especially when you're starting out. I know that within my own specialist training, there was a big thing about you can't get anything wrong. It's important to be right. The stakes are high. But how can we still foster an environment that is safe, bearing in mind that we come from this era of perfectionism. How do we foster an environment that is safe for junior doctors?
Yes, I think one thing we do well in our medical field is mentorship. You know, forming those two-way relationships with junior doctors, taking on the responsibility as a senior doctor to mentor others is quite helpful in guiding doctors to have conversations where they can feel safe to express what their challenges are.
Thank you. Thank you. So for now, let me quickly look in our Q&A and I will get back to you. Right. I think there was a comment that said, well said, influence is earned and not by authority. Okay, essentially we have a lot of positive feedback. So that's excellent. I think there was a comment made from someone that asked whether Sama would be able to provide this coaching. I think that if we get enough support, we can certainly reach out to you and figure out how we can link you with a lot of our doctors. I think this is something that a lot of our members would certainly benefit from. Yeah. I think then, secondly, I know Renier has posted the link for those who didn't get a chance to scan. The link is in the Q&A for members to, at their own leisure, access and go through the quiz. But I think maybe following up onto what I had mentioned about making these safe environments, is there potential perhaps that leadership training can be embedded in more of the training in medical school and specializations? Any thoughts on, how we can go about that?
Yes, so I think this is an ongoing conversation around how to include leadership. And I think the mindset possibly is that clinical leadership has been considered leadership. And where I think the bigger gap also lies is in how to transition to leadership. And that can start very early on. Some of my clients are medical students that are involved in student government. So that's a good training for leadership as well. But that would be a decision that medical schools would have to, explore. And there are, for example, in the US, specific certifications. For example, there's a certification called a physician executive, so you can become a certified physician executive, which is something that gets done much later on. But yeah, it's certainly the sooner one kind of gets an understanding of leadership, I think the better it will serve not only the individual doctor, but the team and ultimately the patients and the healthcare organization.
And then while I have you, I guess my last question is, lastly, how did you transition in terms of the difficulty from getting, you mentioned that direct positive feedback to now being a leader and being patient to wait for, I guess, months or maybe a year for you to get that validation? How did you deal with that? And how did you deal with no longer being primarily a clinical physician to transitioning towards healthcare leadership?
I made all these mistakes. That's how I made mistakes. And fortunately, I have been fortunate throughout my career to have mentors in the workplace. There were other doctors that were in leadership positions who would guide me and who would give me advice. So it is quite possible to learn. You have to be open to admitting that mistakes and reflect on those mistakes. Get support around you. The colleagues can also help you and guide you. Because as I said, mentorship is a two-way process. So you have to actively reach out to mentor to guide you. And then, of course, in different parts of my career, I was privy to training, which I also took advantage of. But that transition for me was particularly painful, and I made literally all of these mistakes.
All right. So is there any way that we can find you? I know you mentioned we could have checked your QR code initially. Can you maybe let us know your LinkedIn tag for those who missed the beginning of your talk?
Yes, my LinkedIn, if you just put my name, Dr. Nondomitho Makune Stevenson on LinkedIn, then you should be able to locate me. It's Dr. Nondomitho, it's physician development coach. I think that's the URL. Yeah, it's if you just put my name in LinkedIn.
Awesome. All right. Thank you so much for your time, and thank you for that exciting, refreshing talk. Have a good evening. Colleagues, we'll be moving on to our second speaker for the day. Our second speaker this evening is Dr. Sipiwo Ngomo. Dr. Ngomo graduated with an MBBCH degree in 2011 at Wits University. He completed 2 years of internship at Chris Hani Baragwanath in 2013 and community service at Embulweni Hospital in Mpumalanga in 2014. He then joined the surgery department at Witbank Hospital as a medical officer in 2016 and completed specialization in general surgery at the University of Pretoria Circuit. He is currently subspecializing in upper GIT surgery, so this is in surgical gastroenterology at the Steve Biko Academic Hospital, and is also part of bariatric and metabolic surgery unit at the Steve Biko Academic Hospital. Dr. Ngomo, over to you.
Good evening, everybody. Let's see if I can switch this thing on.
I can see your screen and you're in presenter mode.
Okay. All of this. Okay. Now that I've joined all these talks, it feels like I'm out of topic. But the good thing is, my talk is purely clinical. I was asked to talk a bit of the relevance of H. pylori antigen testing in the community. The introduction is already laid out. There's nothing further for me to say there on that short CV. Good thing is, I didn't prepare a long talk. As we are all aware, this is an evening talk. We all want to go and rest and get ready for tomorrow. So I'll talk a bit about the introduction, about the background of H. pylori and how it is actually transmitted and causing disease in humans. And then I'll talk about the different H. pylori testing method, the pros and cons of it. And then obviously we're going to touch a bit on the public health, but mainly the clinical implications of H. pylori and the limitations of it. Okay. So,
Dr. Ngomo, are you able to, sorry to interrupt, are you able to put on your camera?
yes, let's see. Sorry, I thought I did. Right. Now everybody can see me?
Yes.
Okay. Yeah. So this is an old bacteria actually. It was discovered back then in 1982. Initially thought to belong to a class of bacteria called the Campylobacter. Who was patient zero? We all don't know, but human genomic studies suggest that humans actually got infected about 58,000 years back. And since then, there's been a lot of investigations on and tracking the infection of this disease, and it's been projected that it has already affected about half of the world's population. The prevalence rates, they vary geographically and also within different ethnic groups, with the United States recording of about 40 to 50% of the prevalence of this bacteria. But what we notice is that it is more prevalent in developing countries, especially in countries that have high rates of low socioeconomic status, and South Africa being one of them. In Africa, we have good data now coming from the first Lagos consensus, where they established working groups, where one of the working groups was actually looking at the epidemiology. And they actually reported that the prevalence rate in Africa, it ranges from 50 to 90%, depending on where you are, in terms of socioeconomic status and also the race and also geographical location. If you look at this global world map, you can see here that countries in North America, they have quite a little bit of low incidence compared to countries in Africa, with us also ranging there around between 80%, but also because of our diversity as well, it also ranges within the ethnicity groups. As I've said, initially it was thought to belong to Campylobacter, but what we know from it is that it's a gram-negative, it's a flagellated bacteria, helical, and it's transmitted from human to human. There are good studies now that actually support the theory of oral to oral and also fecal to oral transmission, whereby they show that people get infected from infected siblings, and you can also see a transmission from mother to child. And there's also studies also that are done on people that are residing in overcrowded areas that show the increased prevalence on those people. The bacteria has also been cultured in terminal ileum and also rectal fluid, which also supports the fecal-oral route. And also in people that drink contaminated water, there's been shown that in studies that if you do cultures of H. pylori in any drinking water, you can pick it up in almost to 40% of this bacteria. So it is a fairly prevalent bacteria that we see a lot. There is also a concept of genetic susceptibility with a couple of studies that actually looked at different community groups. Fraser et al. Actually tried to balance education, socioeconomic status, and environmental condition. And what he found out is that H. pylori is more prevalent in American of African ancestry. However, there's no specific gene that has been actually isolated that make you susceptible to H. pylori. There are other studies. This one was done in Arab Israelis, whereby they realized that the prevalence rate is actually higher in low socioeconomic villages, but was equal in all ethnicities, which also probed the whole situation of genetic susceptibility. Identifying high-risk population is of utmost importance. In South Africa, we have a lot of communities with low socioeconomic status, and that is our biggest higher risk for contracting H. pylori. Poor sanitation and overcrowding, I've already mentioned it. Other risk factors, we still have communities that are using traditional pig toilets, or even worse, they still don't have no toilet at all. So the fecal-oral route of transmission, they become prone to that. Poverty, there's nothing good that comes with poverty. We know a lot of diseases that are associated with poverty. And I've already mentioned about the whole issue of drinking water. And surprisingly, being a farmer actually predisposes you to contract H. pylori. The pathogenesis of this is an interlink of three factors. The host factors, which is you being the human. There are many things, as we all know, that the H. pylori has been cultured also in saliva, has been cultured in stomach, terminal ileum fluid. So it can grow everywhere. So I'm not going to go into the whole immunology reaction of what happens in the host actually when you encounter H. pylori. But what you need to understand is that there are host factors that makes us susceptible to contract H. pylori. The virulence factors, we are all familiar with the bug itself from microbiology. They've contributed a lot of information on how actually H. pylori, because of its nature, it's got flagella that allows it to mobilize through easily in the epithelial lining, and it produces an enzyme called urease, which converts urea into ammonia and carbon dioxide. And that ammonia itself, it causes a lot of destruction in the mucosa of the stomach. Also, it also has a different liposaccharide that helps it adhere to epithelial cells very easily. And there's also the element of secreting exotoxic enzymes, which are directly causing destruction into gastric mucosa. The host immune response is mainly, I think the important thing is it's all about the KEGA and how it actually facilitates the pathogenesis virulence factors of the H. pylori. So the consequences of it is that once you have a chronic infection of H. pylori, is that 85% of these patients, they will have chronic gastritis. The good thing is most of these patients, they are asymptomatic. And you will see only a small amount of patients whereby they will continue and develop what is called multiple lymphoma. 10% will have antral gastritis that we usually see, which is basically a pathway to actually forming an ulcer. Either you form a pre-pyloric ulcer or a duodenal ulcer. And then 5% they will have what is called corpus gastritis. These ones, they have decreased acidity, and this corpus gastritis can also become chronic atrophic gastritis, which 5% will form a gastric ulcer, and then the other 1% become intestinal metaplasia, eventually become dysplastic and form adenocarcinoma. There are other non-gastric associations. We don't have good data on them, only in iron deficiency anemia and ITP, whereby we have at least good studies that show that there is a strong association between H. pylori and those two conditions. The other conditions, scleroderma, idiopathic urticaria, Raynaud's, migraine, Guillain-Barré, and acne rosacea, we don't have a lot of studies that actually link the two, but there are theories that suggest that infection with H. pylori is linked to these diseases as well. So which individuals need to be tested for H. pylori? There are standard indications to test, and there are controversial indications, and some of them will follow them and some of them will don't follow them strictly. For instance, a simple indication, if you have a patient with an active peptic ulcer, either be duodenal or gastric ulcer, it is prudent that you can test that patient for H. pylori. In South Africa, we're still not doing that. We basically treat the ulcer and eradicate empirically. Patients with a history of peptic ulcer disease without prior treatment of H. pylori, these are the ones that usually most gastroenterologists, they start testing. Patients with low-grade gastric malt, obviously you have to test this patient, because if you treat the H. pylori, actually the malt lymphoma will actually disappear. And patients with after endoscopic resection of early gastric cancer, also they need to be tested. I'm not sure of how many people are actually doing that routinely. And also patients with functional dyspepsia that have never been investigated in high prevalence areas like ours. So we have to actually test them as part of the indications. Controversial indications, as I've already said, patients with functional dyspepsia, but in an area whereby the prevalence is less than 20%, those areas are very scarce. It has to be urban areas where they have clean drinking water and so forth and so forth. So those ones, there's still controversy on whether we should test them or not. Chronic NSAID use, the problem with chronic NSAID use is that these patients, they present with chronic erosive gastritis, or worse, they present with chronic diffuse ulcers, which makes you think that they have chronic gastritis. Therefore, you will always be tempted to test them. So other people, they test them, other people we don't, because we know that they are using NSAIDs, and that's why they are having erosive gastritis or diffuse gastric ulcers. Chronic PPI use, there's a little bit of discrepancy of what to define as chronic PPI use. Other people are using 5 years, other people are using 10 years. But if a patient is being on chronic PPIs for whatever reason, it is prudent that you can also need to test that patient. I've already mentioned the strong link between iron deficiency anemia and ITP. However, there's still controversy on whether we should test everyone that presents with iron deficiency anemia or ITP routinely for H. pylori. Patients with a first-degree relative with gastric cancer, it makes sense that you must test them. And then patients with a first-generation immigrant from a high-prevalent area with gastric cancer, these are your Latin Americans, your Asian people, and also people from China. We say there's still controversy on whether we should test them or not. There are different types of testing methods. There's non-endoscopic methods and there's endoscopic methods. Obviously, if you look at this, you can see that the endoscopic method, they are kind of like labor intensive in the sense that you have to now do a gastroscopy to test them and so forth. Therefore, it makes the non-endoscopic testing method more appealing. What I put first there is the stool fecal antigen testing. There's also something called urea breath test, which I will describe, and also there are blood tests. Blood tests are not really reliable because basically they are checking ELISA, they are checking antibodies. I mean, if you have a prevalence of 90% infection, if you test everybody, will basically test positive, So I don't think it is that reliable. And endoscopic testing method, we've got culture and histology, which most people are accustomed to. And we also have rapid urease testing, and there's also PCR. The unfortunate part of it is that you can't just patient walk in and you just start testing them. There has to be some sort of preparation for testing. The reason being is that the test are affected by many things, such as antibiotics. So the patient should not be on antibiotics for at least 4 weeks before testing. Patients on PPI already, as I said, these patients, they come in already with active ulcers. Already, some of them are their own PPI. So if you're going to test them, you have to be at least 2 weeks off PPI before you can test them. Bismuth preparation, we're familiar with bismuth because we use it for treatment of as a salvage therapy or second or third line therapy for treatment of H. pylori. So again, these patients must be at least off 2 weeks before testing them. And some of the tests, they require that the patient must be fasted at least 6 hours before they are tested. The stool antigen testing, which is what I'm in favor for, is very easy, and it can be done by anyone. It can be used to diagnose, and it can be used also to assess the success of treatment. So the stool can be collected by the patient at home, and therefore the patient can bring the stool either in the hospital, or it can even bring the stool to the GP and then send for analysis. What it does is it detects enzymes or proteins that are produced by the H. pylori. So they do enzyme immunoassays on it. You can either do a monoclonal testing or polyclonal testing. We have enough evidence now that shows that their monoclonal testing is actually quite accurate in detecting the disease, in both for diagnosis and also to assess successful of treatment. However, when it comes to the polyclonal part, we're still not sure. The advantages of it, it's non-invasive. You don't need a scope for it. Pooping is a physiological process. The patient collects the stool, and there is administration. As I've said, even GPs, they can do that, and you get the results quicker. And in terms of cost, it's quite cheaper compared to the other ones. The limitations of it, of course, is there's false negatives, especially if you trying to assess for treatment and you do the test less than 4 weeks after completion of treatment. Therefore, you will get false negative. You can also get false positives in it, and it's also here I wrote that it's not great for monitoring of successful treatment, but in actual fact, it's great for monitoring successful treatment. It's just that you have to do it at least 4 weeks after the treatment. And the patients obviously must be off antibiotics and other things that would affect the stool antigen testing. Urea breath test, it's quite simple also to do. It also doesn't need endoscopy. Basically, H. pylori, as I've said initially during pathogenesis, is that the urease breaks down urea into ammonia and carbon dioxide. So when they give the patient to ingest a solution that contains urea labeled with a non-radioisotope carbon, they can either use 13 or 14. Therefore, then they give a patient a special bag, the patient to breathe out the air after ingestion of that non-radioisotope carbon. Then the air is analyzed for carbon dioxide, right? And the amount of carbon dioxide then tells us that there is H. pylori in the stomach. However, this urea breath test, the patient must be starved before the procedure, so the stomach must be empty. The advantages is that it's the same as the stool antigen test. Also, it can be done at outpatient setting, it can be done in GP rooms, and you get results within a few hours. And in fact, in studies, it's been shown that it has a very high sensitivity and a high specificity. However, the limitations of it is that it is expensive. Other thing is that there is that small radiation dose, even though they are saying it's neglectable, but it's still radiation. And of course, the patient needs preparation. However, you also get false negatives, especially in patients that are taking PPI and also patients that are taking Bismarck. Endoscopic testing, most people are doing endoscopic testing because basically you pick up those patients that fit the criteria for standard indication for testing. So you've got direct ones and you've got indirect ones. The direct one is basically a culture. Just like any blood culture, you do a culture of H. pylori. Obviously, the disadvantage of that is that it's going to take 2 weeks to grow. But there is a big advantage of it. If you do a culture and the H. pylori actually grow, it offers you antibiotic sensitivity. You will see that one of the growing concerns of this H. pylori testing nowadays is the whole issue about antibiotic resistance. So if you do a culture, you get also antibiotic sensitivity. So that is a big advantage. However, transport for anything that requires a culture, there's always going to be issue about storage and the growth media and all sorts of things. Therefore, those things, they will affect the results. Histopathology is considered to be the gold standard for diagnosis. However, you need a dedicated pathologist who's dedicated in picking up H. pylori. There are different stains. They can pick it up with different stains. Even the normal cheap H&E stains, there are also special stains like silver, ginger, and ginger that can be used. However, it can be affected by biopsy site. Now, by biopsy site, there are many studies that look at where exactly you're supposed to biopsy for histopathology, but we now have studies that actually just look at single biopsy. If you take a single biopsy at the incisura, you're most likely going to pick up H. pylori at about 90 to 100% sensitivity. And there are studies that also look at just taking 3 random biopsies in the stomach, and also studies that only looked at taking 2 biopsies in the antrum. So all those techniques, they've been shown that you can get a good yield from just taking biopsies. So that really cannot be a major issue. Indirect tests, you've got what is called a rapid urease test. You've got gel test and you've got the strip test. The gel test is the well-known claw test, but the problem with the claw test is that it can take up to 24 hours for you to get the result. The strip tests are much more appealing because you take the biopsy and you put it on the strip, you put the runner. In about an hour, you know the results. So most people are familiar with that. They are easy and convenient to use. The advantages of testing, it allows us to have early detection and treatment of H. pylori. And by eradicating it, actually, it reduces the gastric cancer risk and death from gastric cancer, as many are aware that gastric cancer is one of the lethal cancers that you can ever have. Community-based testing in high-risk population can also be used as a primary prevention for gastric cancer. So for me, the advantages of testings, they are very obvious. However, either does it really fit a criteria for us to actually screen and empirically treat everyone or not, I'm not too sure. Treatment failure is a big problem. We see a lot of patients that come back with recurrent ulcers, mainly because they fail to treat the H. pylori. And it's considered if you have a positive urine breath test or on histology or culture or any of those strip tests that you can do after therapy. The issue is you need to know when exactly and which test to use to assess your success of treatment. As I've said earlier when I was describing the different types of testing method, the stool antigen testing actually is much better. However, you need to delay your testing for about 4 weeks after completion of therapy. Of growing concern, I've already mentioned the issue about resistance. There's a lot of resistance that we see, especially with the use of clarithromycin. The success rate of eradication therapy using clarithromycin-based regimen is significantly reduced in the presence of clarithromycin resistance. The good thing is in South Africa, we still have a good response from clarithromycin because we're using a lot of flagyl, but there is patients that are already resistant on clarithromycin. There is also emergence of multi-drug resistant H. pylori, which now raises a question of looking for other solutions. So there are factors that affect the whole issue of resistance. Obviously, the lack of screening programs and also the follow-up after eradication. Most patients, once you've eradicated, you've treated their ulcer, they go away, you never see them again. However, there's also the evolvement of the pathogen itself. It's starting to mutate now, as we all know the behavior of bacteria. You give them one antibiotics, when they come the second time, they have changed how they behave. And then the host as well, there is the issue of adherence. Remember, most studies have shown that the patients must be taking antibiotics for at least 10 to 14 days. So imagine if you're taking those 2 antibiotics for 14 days, people, they stop at 7 days, all sorts of reasons. So the issue of poor adherence as well is a real thing. And then we spoke about the genetics as well. There are people that don't do well when they have a bacterial infection generally. Public health implications, obviously, is a big concern in Africa because of its association with various gastroduodenal conditions and peptic ulcer disease and gastric cancer. And in fact, the WHO in 1994 actually classified H. pylori as a group 1 carcinogen. So we know that it causes gastric cancer. And the link to gastric cancer is actually similar to that one of HPV and cervical cancer. So if you look at it, actually, it does fulfill the Wilson and Yagna criteria for successful screening program, which is one of the reasons why there is now an Africa consensus on how to actually manage and approach the disease, which was established in 2022 in the Lagos consensus. So this criteria basically it's an old criteria that was used for screening any diseases. If you look at H. pylori, it is a serious public health problem, and there is accepted treatment. I've already mentioned that the treatment can be given by the GP, can be given by the clinics. There's good facilities also for diagnosis and treatment. However, obviously there is expense attached to it, and the issue is the latent stage. The latent stage, most people are asymptomatic when they have H. pylori. They only present to us when they have the consequences of H. pylori, whereby they have the ulcers or they have a lymphoma or they have gastritis. So the symptoms is not easily recognizable. There should be a suitable test for examination. Yes, we do have it, and the test is acceptable to the population. I mean, we've been doing this test for many years now. It is acceptable, and we know the natural history of the disease, and there should just be an agreed policy on how and whom to treat the patients, which in our setting, as I've said, GPs can also treat the patients, physicians, they treat the patient, and also us surgeons as well. Now, if you look at all of this, H. pylori basically does fit this criteria for screening. And now the question is, why are we not screening this for H. pylori? Well, there's levels of interventions. So before we embark on screening, I think there is a primordial role whereby we need to fix our social issues first. Because as I've mentioned in my earlier slides, that it is strongly associated with low socioeconomic status. So if the first thing we have to do is improve the socioeconomic situation of our society, and also fix the environmental conditions. The primary prevention as well, this mainly talks about the sanitation and hygiene, and also provide better safe food preparation. Secondary, this is where most of us start to get involved. The gastroenterologist, the GP, and also the clinics, these are the people that can facilitate the secondary intervention, whereby we start early detection. So anyone with a sibling that has H. pylori, or anyone with a sibling who has treated, or anyone with a mother who has peptic ulcer disease must be screened. Or should we just go into a population screening basis whereby we screen everybody, or we just screen high-risk individuals and then we treat those people? Tertiary, which is where I'm sitting, I'm basically managing the complications. These are the patients now that comes with all these bad ulcers, and eventually the ones that comes with gastric cancers. So there is stepwise approach that we can approach this thing. And all stakeholders need to play part in it. Treatment, as I've said, there's available treatment. We have a stepwise approach whereby you can give a standard dose of a PPI and double antibiotics. If that doesn't work, you can move to quadruple therapy whereby you add Prisma salicylate, or you can use what we call sequential therapy, which involves starting a PPI with amoxicillin followed by a PPI and clarithromycin or metronidazole. Or you can use concomitant therapy, whereby you use all three antibiotics plus a PPI. There is also a levofloxacin-based triple therapy. And the issue of probiotics, we're really not sure whether they work or not, but some people, they use them as adjunct to antibiotics just to reduce the side effects and also to improve the eradication rates. Duration of treatment, I've already mentioned the older studies, they mentioned 14 days, but we've got good data now that compared 7 days, 10 days, and 14 days that showed that there was little difference actually in terms of eradication rate. So me, I usually choose the middle ground of 10 days. However, if you see that your patient requires 14 days, then they are not in the dark. The limitations of screening, the main one I've already mentioned is that the issue of antibiotic resistance. Obviously, if you screen, we're basically going to put almost half of the population into antibiotics, and that will result in bacterial resistance, which is a major challenge on its own. So in conclusion, the burden of H. pylori, it's quite real, and it has multiple public health implications. So I figured stool antigen testing, it's easy and it's cost effective to detect early infection and also to assess success of treatment. However, there's a little bit of cost attached to it. Mass treatment, however, will decrease the burden of infection and eventually decrease the incidence of gastric cancer. obviously the concern of overconsumption of antibiotics and eventually multi-drug resistant bugs will be an issue. Thank you.
Thank you so much, Dr. Gombo. That was very interesting. I think also particularly interesting that you had mentioned the clarithromycin resistant H. pylori, because in my setting, I think it was 2 weeks ago, I performed a PCR on a gastric biopsy and it was multi-drug resistant. And I didn't think we had such in South Africa. So it really is a developing entity, even in smaller areas. We have a question from one of the panel members, and the question was regarding stool antigen testing. What is the percentage of false positives and false negatives?
It's very low. It's very low. However, it's mainly affected by how you actually test the patient. As I've mentioned, that the patients must not be on PPIs, they must not be on certain antibiotics, and they must prepare as well. So it's very low.
Thank you. And maybe back to my own question is, what has been your experience with regards to these drug-resistant H. pylori infections? Have you had a couple of those in your practice yet, or is it not that common in your practice?
Because we don't really test a lot, you really test on that one on that you see that keep on coming with recalcitrant ulcers and stuff like that. So we don't see a lot of this resistance. But what I've noticed is the patients that are allergic to penicillin, those are the ones that usually end up being in a problem, because our first line therapy is we're using amoxi with flagyl or clarithromycin. Now there is always that question that if you are allergic to penicillin, what then should we give you? And people, they end up giving only the clarithromycin alone, or they give the clarithromycin and the flagyl. It sort of doesn't work. So those are the patients that usually come with the issues of resistance. The good thing is what we've seen in South Africa is that the H. pylori that we have here is that it's quite sensitive to the flagyl, so which is a plus for us.
Thank you. And we also have a question from James Smith. His question was, how frequent is reinfection after treatment in high prevalent areas? And that'll be our last question.
Yeah. I must say, we don't have data on that. I've looked at that Lagos consensus as well, whereby they established a working group where it looks at the epidemiology, and we still lack a lot of data on the infection rates and also the reinfection rates. We lack a lot of data on that. Like I said, most of these patients, we see them at tertiary level already with ulcers. We eradicate them. Once the ulcer is healed, they disappear. So we don't have data whereby we're tracking them on whether they are staying eradicated or not. We don't have that kind of data.
Thank you so much. Thank you for that very interesting talk. I think as a histopathologist myself, it's something I see on the daily. So it's interesting to know what the surgeons are seeing out there. So thank you. Our colleagues, for everyone who is logged in, thank you for your time. Thank you for engaging. Thank you to all our panelists and all our speakers for giving us your valuable time and wanting to impart knowledge to this group of doctors. Have an amazing evening, everyone. See you next time. Bye.